sterile tissue, cardiovascular surgeons may use valves to repair acquired and congenital malformations, revascularize limbs through conduits. Neurosurgeons will use nerves for reinnervation, for cranial vault reconstruction, of course, bone, and general surgeons may use several tissues like a cellular dermis to reinforce the abdominal wall or do soft tissue repair. The blessing number 4 is the ease of use. Because you don't need to cross-match tissues to recipients, and therefore there's no need for immunotherapy after transplantation, so you can expand utilization. The techniques used in transplantation are the same as the ones you do normal surgeries in autologous cases, so there's no need really for specific training or qualifications required, but of course for corneal transplantation. But for example, this picture of a burned child that has been grafted with skin from the tissue bank is a clear demonstration. It's exactly what a plastic surgeon would do with a skin that was taken from the patient himself in a skin grafting procedure. And that's very important why skin is so useful in, for example, war emergencies. No special hospital infrastructure is required for transplantation. No need for ICUs, fancy surgical settings, or equipment. But something that doesn't happen as often, and there are some consequences for that. First of all, as Martin puts together, we are the little sister of other MPHO transplantations, so ultimately the benefits probably under-recognized, and therefore the whole activity seems to be a little bit under-resourced, to say kindly. But important to this meeting, the risks of tissue transplantation are also less recognized. We mentioned that there's less awareness to the extent and impact of the activity. So whilst the benefits are less understood, of course, the risks become underrated, with lesser engagement in policy and regulations. And as we said as well, tissue transplants may be treated as commodities rather than human-donated material. So there's a strong commercialization inroads, as I mentioned, potential increase in cost, generation, further imbalance to access, but also creating sometimes logistical barriers, and I put logistical here in brackets, about the identification of adverse events and information back into originated tissue establishment, that first process, and the closure of the circle. The data collection of the activities, usually at high level only, if any, of national or regional scope, via non-comparable or incomplete data sets. And of course, that complements the feeling of under-recognition of the scale of the donation transplantation activity, of the demand, and of the capacity of supply. And to add to all of that, there is limited follow-up of transplantation outcomes. There is very low level of registration of utilization and or identification of adverse events. Again, except corneas, because we do know that there are very robust registries in diverse countries in the world. And I was looking for interesting material to put into this presentation. I came across another important event of infection transmitted through musculoskeletal allografts, and that was the transmission of Clostridia in 2004. And of all the important information, I came about this discussion sentence, which the authors would say that probably the difficulty in identifying these events at the time and where the tissues had been transplanted was because clinicians presume that allografts are sterile. Allografts are not usually considered a potential source of infection. And I think there was an interesting comment among all the other important contributions in that article. So we highlight that there are no global minimal agreed standards on quality, safety, and efficacy. So there's variable quality and safety standards in donor screening and manufacturing. The standards and oversight of quality, safety, and efficacy for export-important tissues do not fare much better with inexistent or ill-defined. So there are potential gaps in biovigilance capacity as well. And unfortunately, there's some bad news. Although risk is never zero, and probably that's not as high that should preclude activity, sometimes process controls may fail, and we need to keep that in our back burners' minds. And so you can donate tissue, but Still, there may be a failure in donor screening, in the processing, in the testing, in the donor graft data review. And whether we like or not to face this reality, there may be a chance that an unsafe graft is distributed. But I also want to highlight here that my concerns today is not just about unsafe grafts, but also grafts of poor quality, because the more we start manipulating these biological materials, more changes we are creating. And these changes may come to findings 5 years post-transplantation, 20 years. So we need to have that also as part of a vigilance of what we're doing. Tissues from the same donor may be at varied places and used at various times. We need to remember that, and by multiple surgeons. So there's a lag in identification and notification of adverse events. And tissue banks and distributors today may use proprietary product denominations and coding systems. So there are no harmonized product identification. There are language discrepancies. There's no standard labeling. And to make things even more challenging, there can be hardship in determining origin, manufacturing, and implantation of products from donors to recipients. So honestly, there is limited capacity of national and international traceability and product recall in the realm of tissues. We heard extensively about the events of tuberculosis, but they bring 20 years later almost back to the room the same difficulty in locating all the transplanted materials. So I'll leave all of us here with these ideas, and this picture I hope will not be the end of our discussions. At the end of it, it will be not similar, because if you know, both St. Damien and St. Cosmas were decapitated, unfortunately. So thank you for the time with me. Thank you.
So I will invite our second speaker from United States, Scott Olson. And we will hold, like yesterday, all the questions until the end for our panelists. Thank you for that wonderful talk. So from tissues to cells.
From tissues to cells. Can everybody hear me okay? All right, 6-1, and I know the microphone can change a little bit. Well, good morning. About 3 months ago, I was wondering how I was picked for my organization to give this presentation, and we're about to find out why. So what you're seeing in front of you is really going to be in basic elementary education. For the majority of you, you already well know all of this information, so it's very basic, but specifically for those that are more used to other areas like milk banking and other aspects of MPHO, hopefully this will be beneficial. And the majority of the content you'll find is also taken from the Notify Library's 2018 booklet, so it's publicly available. Please go out and grab it. I have no conflicts of interest to note. However, because we're in Rome or Italy, I'm readily accepting caprese salads, so if anybody wants to share or enjoy one. So stem cells is MPHO. Really the primary donation type in the US is voluntary donation by living donors. One-to-one to recipient who does have informed consent, so some of the variability between the other types like tissue. Typically as a part of hematopoietic cell transplant for a variety of malignancies, use of ISBT 128, and reporting may be based on multiple regulating bodies. Really, that's dependent on the country. For a useful transplant, we need several things. Really to replace the immune system, which requires first and foremost preparatory regimen to essentially eliminate the patient, the recipient's original immune system, differentiate into desired cell types, or in this case, blood, integrate into surrounding tissue after transplant, depending on the type of transplant we're talking about, and avoid rejection by the recipient's immune system, function appropriately for the duration of their lifetime. Again, elementary level. Two types of stem cells, pluripotent stem cells, so those that are undifferentiated, and those that we'll focus on in adult stem cells, so differentiated to the specialized cell types. We're going to concentrate on the hematopoietic progenitor cells, or those that are blood-forming cells. We can find them in the bone marrow, or HPC marrow, which is about 20% of the transplantation. Peripheral blood stem cells, or HBC apheresis, about 80% of those transplants now, and umbilical cord blood, which is somewhat fleeting. What we're seeing right now is concentration on the impact to the donor. So HPC marrow and the collection. So we talk a lot about preserving and the safety of the donors. For marrow donation, products are most often collected in surgical suites with donors receiving general or regional epidural or spinal anesthesia. You have common donor reactions like bone and back pain, anemia, fever, headache. You also have more severe reactions, while rare, that also include death, stroke, air embolism, chest pain, endocarditis, fat embolism, and iliac fracture. HPCA, so this is apheresis donation. Commonly involves mobilization of the HPC from bone marrow into the peripheral bloodstream via a mobilizing agent. Common donor reactions are headache, bone pain, splenomegaly, and thrombocytopenia, and more severe reactions, arrhythmias, splenic rupture, and vascular problems. So apheresis and obviously marrow collection is no picnic, but apheresis is so common and so well done that the majority of these complications don't happen very often. They still involve acute, immediate, or chronic or delayed central line thrombosis if they need a central line, citrate toxicity, hypotension, infection, mild leukopenia, and thrombocytopenia. Again, there are also more severe reactions as well. There's going to be differences in reporting and follow-up recommendations of donors. So adverse occurrences, again, we're concentrating on donors to begin with. Really should be concentrated around the time of donation to about 30 days post completion of the collection or the donation. Reporting of hospitalization-related occurrences can occur frequently because of the confusion between, especially in HPC marrow. Common hospital occurrences, whether it's or complications like nausea, vomiting, pain, and headache, and those that are associated with the actual collection procedure itself. And long-term follow-up of donor annually or biannually for at least 10 years, shorter than organ donation, which is the lifespan. Talking about the impact to the patient or the recipient, I like to use recipient because I think everyone here is a patient at some point. Infections, relevant communicable disease agents, or our wonderful acronym RCAD or RCDAD, graft failure, graft versus host disease. In fewer of the other donation types or MPHO, you have an instance where the donated material can actually attack the host and effectively kill the host in rare occurrences. Genetic transmissions of mutations known to cause disease. How do we combat this? So taken from FDA's 21 CFR 1271, some of the common testing types are for HIV, hepatitis B, C, treponema, and there's additional testing for donors of leukocyte cells or tissues. There's also a donor medical history review, which is only as accurate as the donor speaks to. The laboratory test results that are available, medical records, in the rare instance or fewer instances, coroner and autopsy reports, and records or other information received from any source pertaining to risk factors of relevant communicable diseases. So interesting, we have a portion of the industry or MPHO where we have to, like others, not include a donor's name, personal information that might identify them. So how do we have traceability? And especially when safety is timely notification plus traceability, we have any potential adverse events, malignancies that are identified in the recipient that need to be traced back through the entire process to the donor, because we may have a donor that needs to be notified of a concern. And that's where ISBT 128 comes into play. So that international agreement on product descriptions and unique identification of each donation is effective traceability on a global scale. That's what I have for us this morning. You know, I tried to make it as fast as I could.
Thank you so much. So many particularities, as Marissa said, unique to HPCs versus tissues. So thank you for that. And our third speaker.
Our third speaker is Agnieszka Nowak from Poland, and she is representing the European Society of Human Reproduction and Embryology.
Thank you. Good morning, everyone. Buongiorno a tutti. At first, I would like to say thank you, a local organizer, and ICCBBA for inviting me for this opportunity, and I could take a part to this meeting and exchange the knowledge with everyone. So thank you for that. I represent the European Society of Human Reproductions and Embryology, but I'm from Poland. I live in Krakow, and I work in a private sector in IVF center where I am the head of the laboratory. So I work as an embryologist. So working with sperm, eggs, and embryos, it's my daily routine. So European Society of Human Reproductions and Embryology, which I represent, was convinced by Robert Edwards. So I'm sure that remember this guy and know this guy because he received the Nobel Prize for first in vitro fertilizations procedure in a human. And actually, nowadays, our society includes more than 10,000 members, mostly from European Union, but also connect the members from whole the world, connect the scientific specialists, connect the embryologists, medical staff, and also patients' organizations, which is important. The main goal of ESHRE is the disseminating research in human reproductions mostly, also develop the guidelines and good practice recommendations for our members, but also ESHRE supports the research and of course represent our members, interest of our members on policy makers. So medically assisted reproductions, it's very often referred to as assisted reproductive technology. And when you see the publications and when we spoke with other members, we mostly use the assisted reproductive technology name. So sometimes I use this name at the same time. But medical assisted reproductions is broader term and includes also the techniques like ovarian stimulations, which is the first step of procedure when we perform the fertilizations. It's the procedures, it starts the procedures when we stimulate the patients and then collect the oocyte before two fertilizations. And also include the smaller procedure, we call it smaller like inseminations, using the sperm of the donor's partner of anonymous donors. So medical assisted reproductions include diverse procedures such as intrauterine inseminations, as I mentioned, so where we proceed the sperm and then transfer it to the uterus close to the estimation time of ovulations. It includes also IVF procedure, in vitro fertilizations, either conventional, when we connect in one dish motylized sperm and eggs, and also include the more advanced techniques such as intracytoplasmic sperm injection when we put the sperm into the mature oocyte, and of course include the part where we culture the embryos to the transfer or freezing time. Also, MAR includes in vitro maturations technique when we recover the oocyte from non-preovulatory follicles, and this oocyte finish maturations in vitro conditions. And also include diverse techniques such as cryopreservation. It's a very broader part of our fields. We cryopreservate the gametes, zygotes, embryos, and also tissue. And a very important part is storage this material in proper way. Also include pre-implantation genetic testing. In this part, we use screening of embryos, but also in some countries, we screening the oocyte, because in some countries, the screening in embryos is prohibited. So we're screening the oocytes, it's germ cells. To known inherited disease to prevent the transfer embryos which carry this disease. And also include the broader part, it means protections of biological material before or during treatments for the patient, during the treatment for cancer or other disease which can affect on fertility. It calls the oncofertility procedure. So when we perform, it's the European, my point of view version of MRT. When we perform the procedure, we follow the guide to the quality and safely tissue and cells for human reproductions. And also we follow for regulations, European Parliament on standards and quality and safely and substandard human organ intended of human applications. So, but also we have the guidelines in our society, for example, the guidelines of good practice in IVF laboratory, and also most national organizations prepare the guidelines for good practice in laboratory. We work with, I was curious it will be moved or not. We work with diverse type of material. We proceed sperm, we proceed on oocyte on different stage of maturations. We proceed the embryos in different stage of culture, from the zygote stage to the blastocyst stage, and also we proceed tissue, the tissue from testicular or ovarian sorry. So each day we handle biological material from diverse cohort of the patients. So stress in our work is very high. So identifications, the patients, and identifications the cells of the patients on each step of procedure, it's crucial aspect in our MART treatments, and no holds barred. So each laboratory must have an effective and accurate system of identify, trace, and locate the reproductive cells. We use a lot of identification system. For example, some laboratory use ID patients, some laboratory use the number of procedure. We document the color of device when we freeze the material. We document the positions, the dish in the incubator to be sure that we trace the material. We document also the localizations, the material in the tank. It's the device when we keep the material liquid nitrogen. We also support, we also use the scanning the barcode, but there are two types of barcode. One of them is very useful in a reproductive field because one only scan the barcode, but other system, different system makes also the pictures, the barcodes, and the name of the patient. So if you are not sure that you connect the proper gametes, you can back to the previous step and be sure and go calm to your house after the work. So it's very useful. And also when we have the crucial step in our procedure, for example, when we connect the gametes during the in vitro fertilization procedure, we use double witnessing. It means that the second person in the laboratory confirmed that we connect the proper gametes for the donors to be sure. As I mentioned, so we have very stressful work. On the pictures, I present a small device, the yellow one, when we we use this device to freeze the embryos and gametes. So as you see, the labeling, the space when we can put the labeling, it's very small. So that we use the scanner, the second person, and a lot of information to be sure that we work with the proper material, and of course that we connect the proper material. So in European Union, we work with 3 types of coding system, or worked. ESBT 128, Eurocode, and single European code. But from 2015, the European Commission update the requirement for technical requirements for coding of human tissue and cells. And now, as you see on the graph, most laboratories use the single European code in our system. I represent also the Polish society, and from 2015 we use only single European code because according to new regulations, so 100% clinic use single European code. We have in Poland only the private sector. So 64 clinic apply the single European code and using during a daily routine. And of course, single European code should be applied to all tissue and cells used for human applications, but we have some expectations, including case of partner donations of reproductive cells or when donate tissue and cells remain in the same center. So when we perform the fertilizations with the fresh material in one center, we don't use the single European code. When we have the partner donations, but when we freeze the material, all laboratories use the single European code because we never know what happens in the futures, and some patients decided to move the material to other clinics, to other country, or sometimes the patients could decide to donate their gametes to other patients which they have a problem with fertility to give them chance to have the children. In Poland also we have the very crazy situations because patients who has the embryos, they can decide they can use these embryos for 20 years. If they don't use the embryos going automatically to anonymous adoptions. I know that 20 years it's a lot, and there is the chance to make decisions what you want to do with your embryos, but also in Poland we can destroy the embryos because different countries have different regulations, but in Poland we can destroy the embryos. So if you don't use all your embryos, because gametes we can destroy, if you don't use your embryos and if you don't decide to giving them to anonymous adoptions, the policymakers makes your decisions and your embryos going automatically to the anonymous adoptions. Of course, there is the options that you take your embryos to another country, which the policy is different and you can destroy the embryos in different country. But it's a very strange situation now for the patients, and we need to inform the patients before they start the procedure that that situations could happen to inform them previously. And of course, other expectations are when reproductive cells are imported from non-European countries into the European countries in case of emergency authorized directly by the competent authorities. And these situations took place when Russia attacked Ukraine, and Ukrainian clinic asked the ESHRE to support them with discussions with clinic with whole the Europe to receive the biological material and store it because on Ukraine this material could be destroyed. And Polish government accept this possibility, but they agreed just to storage the material, not to use, because it could be the problem with the documentations of the material when we evacuate emergency the material from the Ukraine. But Slovakia accepted the whole material from Ukraine, and material gametes and embryos from Ukraine was transported to Slovakia and then split in the Europe. Of course, they adopt the single European code to identifications, the material. So as you know, we use the single European code with this include with donations identification sequence and product identification sequence. And the donations identification sequence indicates the origin of tissue of cells, mainly because every donor could potentially donate tissue and cells on several occasions. And of course, they can donate the material in different centers. And second part, it's product identification sequence and include the product code, split number, and expiry date. Split number because we very often split the material for different devices. For example, when we freeze the sperm, we split the material for different few straws. Or when we freeze the eggs, we also split it for the group, for example, 2 or 3 oocytes for one device. And in case of embryo, we don't use the expiry date because the embryos then don't have the expiry date. So we used 80 in this coding system. And of course, the single European number has to be printed in eye-readable format, but I show you the small labeling places. When we freeze the material, it's very difficult. So, but we work with this. Special interest group embryology safety and quality prepared the questionnaires for the members, and 91.4% members are informed about the European directive of the coding system. In my country, as I mentioned, 100% clinic use the single European coding system. 49.1 use own specifically defined donations code. So this is space to discuss because maybe we should use the same definite donations code. And the also question was about where you apply the code. So 87.1 apply the code on the accompanying document. So as I mentioned, the device are too small. It's difficult to apply all code on the device. So we use only the donations code or device. Medical assisted reproductions, as I mentioned, it's very broader fields. We use different MAR procedures, intrauterine inseminations, in vitro maturations, fertilization, genetic diagnostic of the embryos and cryopreservations. We use different type of material. We use the sperm, oocyte, embryos, and tissue. We use different origin material, partner donors, non-partner donors, only live donors. And in some country we have anonymous donors, but some country allows to non-anonymous donations. We work with the fresh material immediately after the collections, but also we work with the material which are stored, warm, and then use. We have the different MAR country regulations and also different implementations of material in the identifications in individual countries. When we discuss about challenges for the future in context of safety and traceability and of course coding system, we should focus for new procedures such as mitochondrial replacement therapy when we have free parental embryos. And also there is the still research therapy, in vitro maturation and in vitro grow oocytes. So we collect the tissue, growing the follicles in the incubator and then collect the oocyte from the follicles. And also the challenges part in our fields, it's long-term storage and identifications in material because we storage for long time. We storage a lot of material for a long time. For example, we can use the material after 20 or 12 years of storage. So these gametes are used in anonymous donations, but the quality of storage and identifications of the material during the storage and then during the procedure, it's important. Thank you very much. This is my sitting.
I would invite all the speakers to come forward. And we'll start with the questions from the audience. Okay, too early. Well, maybe I'll start us off with the question. So with cells, specifically HPCs, there is a very unique perspective on donor follow-up and follow-up on reporting on any adverse events during collections. Of course, with tissues, that is way less relevant. Are there any reporting requirements when it comes to ovarian tissue collection when it comes to donor adverse effects?
I'm not sure because it's me. Yeah, maybe my colleagues help me, but it's not very broad field because the most popular donation is egg, sperm, and embryos donation. So I don't think so. Do we have? Okay.
Mickey. Oh, sorry.
Yeah, hi.
Sorry. Go ahead.
Sandra from South Africa. Just a question for the speaker from Poland. You say that you only use live or living donors. So do you ever get confronted with the question of a young man who dies and the wife or the mother would like to extract sperm and save it for later use? We seem to get that increasingly in South Africa. And there's different thoughts. Some say, yes, it's excellent. It can work if you do it within 12 hours. Other guys say it's very dangerous for the future child. What is your view on that?
I know the situations that American soldiers had freezing the material before they going to the war. So this is the opportunity, but in general, we use the live donors and material, but in practical way, collections the material after the death of the patients. Oh, so in technical view, it could be happen very fast after the death of the patients because we lost the quality of the material. So if we would like to use this material in the future, we need to collect it till 12 hours after the death of the patients. Of course, we speak about the technical methods. The different point of view, it's the ethical point of view, how the parents are sure that this man would like to have the children in the future. Of course, they would like to be the grandparents in the future, but it's difficult to be sure that these donors, these patients would like to have the children. So we also should think about his point of view.
Mickey, go ahead.
Yeah, hi, Mickey Ko from London. Question directed at Scott, actually. Thanks for the presentation. Could you elaborate on the strategy for NMDP moving forward into cell and gene therapy and the idea of using your donor pool to collect material for advanced cell therapy and how that's being looked at in the organization? Thanks.
Well, thankfully, I think we took an approach that's very strategic because we actually have a separate entity that's underneath the umbrella of NMDP collectively, which is NMDP Biotherapies. And since I'm not a part of NMDP Biotherapies, I can say I can definitely get you connected with my colleague in NMDP Biotherapies or my peer in the quality department within. It's an interesting approach. I can understand the differentiation between two different organizations, especially given the presentation that I provided and a one-to-one matched donation versus providing cellular starting material. I think it's not speaking for my organization, but my own perspective, that it's an approach towards supporting innovation, but wouldn't be able to elaborate much further.
Okay, so I was just curious to know whether there were guidelines for how these were going to be used, the differences in selecting donors. Were they going to be reimbursed? Do you have any idea?
My understanding is that it is still voluntary donation, and really, I'll also say, I think we spoke about this a little bit yesterday, is when you start working with individual pharma companies or clients is the term that we use, the requirements, the contractual obligations or agreements can be quite elaborate and very specific, and get very confusing very quickly.
So
I hope
maybe
that somewhat answered your question.
Yeah, and I think Lydia would like to add from WMD.
So my name is Lydia. I'm from the World Marrow Donor Association, and we are facilitating unrelated donors globally. NMDP is one of our member organizations, and we have a few members that are facilitating donations for the cell and gene therapy. And at the moment we have published a paper that we highly recommend non-remunerated donations. And at the moment we are in the process of developing standards globally on these type of donations, because it's new, as Scott outlined in our field. It's not a one-to-one donation, it's one donation to several patients. So I really appreciated your presentation with all the challenges that are there in the tissue fields, because I think we can learn from that.
Well, I was going to give a concern, and actually I wanted to finish what you said. No, you had really attractive ideas of how to manage your traceability in the different fields, and some of those at some point can help others to develop theirs in a better way. Just answering the ovarium, and we had an ovarium experience related to the harm or potential problems during collection for women with cancer that we preserve ovarium. I will say that with the previous legislation in Europe, you were not having to give any kind of notification, because you only had to do it if there was a concern about the quality or the safety of the tissue. Now with the new legislation, you're going to have to do it, even if there is not a concern on the quality and the safety. But under my experience on biovigilance, something that goes wrong related to a living donor, usually it's not notified. Usually that's my experience related to kidney living donation, related to anything which is related to living. It is more difficult for the professionals to notify than the ones that it comes from deceased donor. This is my experience. I don't know if it's globally, but when it's concerned to a living donation, a problem during collection, usually it's more difficult. Maybe not in cells, but in organs and tissues, I think it's more difficult for them to notify that there was a problem at that moment.
Thank you for that comment. We have a question.
Thank you. I'm Paola Di Ciaccio. I'm working for the Italian National Transplant Center. I have a question for Agnieszka. You mentioned, I think very correctly, that a follow-up of children's health is part of the traceability process. Have you got, as ASHRAE or in your country, any data concerning the success rate of this part of traceability? Or is more difficult, it's something that goes beyond, coding, just coding?
Apologize. In Poland, we have the central registrations of the donors, and all donors of the sperm, oocyte, and embryos from Poland, and also from other countries, because some clinics use the material from the cryos. It was the presentation yesterday. We need to fill all documentations in this central registry, and when we use this material, we need to immediately also fill the formula in this central registrations. because we have also in Poland the regulations that only 10 children can be born after one donors. So and if one donors have 10 children, the donors is blocked. Even if some couples would like to have the children with the same donors, some clinics ask the Ministry of Health to release these donors, but our ministry don't accept these questions, and we couldn't use the material. So we need also fill the all informations about the children, but of course depends of the situations, because the patients then they don't need to inform the clinics what happens after the transfer, after they use the material. So we have the black box about some informations. But before 2015 and from this year, we have the financial support program from government, and it's financial supported 100%. So the patients then don't pay for the procedure. And in this case, the patients are obligatory to inform the clinics and inform the Minister of the Health what was the results of the procedure. So now it will be better because we will have more information. Thank you.
Thank you. I'm Sunil from India. I'm just curious to know, what's the, after the shelf life of tissues, what is the discard rate acceptable in a laboratory?
Ideally, it will be zero, because you should be planning what you do so you don't need to discard. That's not the reality. Yeah. There are discards along the way, from immediately after donation, from process failures during processing that you detect. What is the acceptable range? It's hard to say. Sure. I think we should strive to zero, but and you can do a questionnaire around the world, and it will vary from 10% to 25 to. But sometimes it seems high. So whatever it is, you should be aware why it's happening and what could be done to reduce that. That would be the message.
The only reason I'm asking this question is to look at demand and supply. Are we kind of producing oversupply for the demand which we have? And that's why I was asking this question, that is there a high discard rate in some of the labs, especially in the US and Europe?
I can respond for every tissue bank. Maybe someone else would like. I would say it's variable. But you should strive for as little as possible, taking in consideration that there will be some discards along the way.
Yeah, this is an interesting subject, and it's also tackled by the new SOHO regulation. So vital loss of tissue should be reported as a serious incident. Whether it's serious or not, it can be a mishap. But of course, then we get quality indicators. What is acceptable? We can benchmark, we can compare between countries, between institutions, and that's, I think, a good thing. And if we have measures, we can improve. So in SOHO regulation in the EU, this is a tackled subject. I think it's a good thing. I have another remark on donors. Within the SOHO regulation, autologous donations and mishaps in donor vigilance are not reported. And that is, I think, a failure of the SOHO regulation, because mishaps in the autologous donor area are interesting to compare. Of course, these donors are also patients, so they're protected. But with leaving this out in the SOHO regulations, we miss information on the autologous donor trajectories and the vigilance and the mishaps in that area. So I don't know whether Stefan is in the room. But it's interesting there's a public consultation on the SOHO regulation at this moment going on up till December. So if you agree with me, please reinforce this.
Can I make just a comment?
The last one.
The most difficult question on ethical grounds comes on embryos destruction. I mean, I know that a lot of embryos have past their shelf life, perhaps. I don't know what to call it. But that's, again, an ethical challenge. How do you handle that? destroying the embryos? I'm sorry, I'm very
I don't know.
uneducated. I'm from the
We
organ
need to-
transplant world, so these are the questions which come up in your mind. So I just wanted to know.
For Aneska, Ms. Erwin Cabana from ICCBBA. Just follow up on your the 10 children limitation. Does that also include the embryos in long-term storage?
No, it includes only live birth. So even if you have your embryos and you storage your embryos when we were created with material of these donors and this donors was blocked, you can use it, these embryos. I know it's very tough regulations. We should still work to improve regulations to understand the point of view of the patients which they have the embryos which are created now. And they're waiting for the transfer, for example, because some patients waiting for the transfer because are in pregnancy, and because they're waiting for the transfer because they need to have special treatments. Of course, sometimes we have the oncological patients, so it's very, very difficult situations. But it's point of view in my country, and before 2015 we had no regulations about in vitro fertilizations procedures. Of course, it's the compromise documents between very liberal fractions and very radical fractions, because we had very radical government previously. And now a lot of people afraid to touch the regulations, to not provoke the discussions, to not move the regulations to more radical way. But of course, it's waiting for us, and we need to start discussions for the future because the world is changed. So of course, the regulation should also be changed.
If you had to resolve any conflict with
the patients or with the
with someone that already had 10 children, but they have embryos in storage, and you can't destroy the embryo.
We ask them, because we are the private sector, so we ask them also to push the government to write the letter to Ministry of Health, to push the patients' organizations, to push the governments, but we have nothing more to do.
Before we close, can I just make a quick comment? May I? Cheers. Just very quickly about discard. If you don't necessarily need discard, doesn't mean in tissue banking that's necessarily going to be discarded into a bin. If there's appropriate consenting and informed consent at time of donation, these tissues can still be used for innovation procedures, validation procedures, and there's a lot of good that can still come out of the concept of discard. Sorry.
Sorry. We have to close this session. I will invite you, if you want continue the discussion, we can do in the break first, because we have delayed for the next panel. Thank you very much for your contribution. It was wonderful.
Hi, everybody. In the interest of time, I think we will attempt to move straight on. My name's Wayne Bolton. I'm from Australian Red Cross Lifeblood, which is the National Blood Service of Australia. I'm also here because I currently chair the ICCBBA Standards Committee. This session is somewhat optimistically titled "In Technology We Trust," which is not reflective of my optimism, more Owen's. But before we go on, I should probably note that originally this session was going to be co-chaired by my colleague, Dr. Joy Mammon, from Christian Medical College for Law, but at the last minute he was unable to travel. So to avoid the risks of me being undiluted, Owen's offered to assist. So we might move quickly to the first speaker, which is Mr. Fintan Jordan, who's an Associate Director for Supply Chain with Horizon Therapeutics in Ireland. And he's going to talk to us about traceability in other sectors, particularly pharma, and whether there are any lessons in that for MPHO. Thank you.
How you doing, everybody? Thanks for the invite, Owen. I've worked in the pharma industry in Ireland for 25 years. Interestingly, my first job in pharma was in blood testing. I supplied kits to Italy, Australia, among other countries, to the blood banks. They were NAT kits. And now working for Horizon Therapeutics, now bought out by Amgen last year. So traceability in the pharmaceutical sector is what I want to talk about today. Serialization with an S, not with a Z, because the Americans tend to use the Z. So it did come across in my presentation. It always comes through. So why serialization? Obviously, counterfeiting in the industry is a big problem. I've shown you two pills there. One is a fake, one is genuine, and obviously fake medicine will not help patients and could cause harm, death. Falsified and substandard drugs. This may have been discussed yesterday. Drugs can cause harm to patients and fail to treat the diseases for which they were intended, may even lead to death. Falsified drugs can affect every region of the world. It can be found in illegal street park markets, unregulated websites, pharmacies, clinics and hospitals. And in the industry, we reckon an estimated 1 in 10 of medical products in low and middle income countries is substandard or falsified. And counterfeits mimic branded or generic drugs. They may include products with correct ingredients, wrong ingredients, no active ingredients, insufficient or too much active ingredient, or fake packaging. So in our industry, in pharma sector, it's something we're very conscious of, and having compliant drugs going into the market is very important. So what is serialization? Previously, before serialization, we worked with barcodes. They were linear barcodes, which would have 13 digits, but they were limited in the information that could be used. So a couple of years ago, I'm not quite sure when, in the last 10 years, I think it was, we moved into the world of serialization. So in simple terms, serialization means giving a unique identifier to an item. For example, a natural form of serialization is our fingerprint, and obviously no two individuals have the same fingerprint, even twins. Aside from pharmaceuticals, other sectors like logistics, aviation, use the concept of serialization. There's a Z there for tracking packages and luggage respectively. And so all of you, or some of you, would have had a bag coming from here, from wherever you were coming from to here, that would have had a tag with a unique identifier. And that's the concept of serialization. And then serialization in pharma. Pharma serialization is the process of assigning unique serial numbers to every drug packaging that is saleable, primary, secondary, and tertiary. So from blisters to bottles to cartons and pallets, they all carry a unique identifier. This unique identifier can either be a QR code or data matrix codes, depending on the country region, and carry information of product's origin and validity. So typically a serialization 2D matrix code would be made up of a GTIN, a global trade identifier number, followed by a serial number. The GTIN is 14 digits, and then a serial number a little bit shorter, followed by a lot number denoting the origin of the product and the manufacturer, etc. And then the expiry date comes on a 2D barcode. These codes are then printed visibly on the respective packaging and are linked to each other. That is, the code of a bottle of drug is linked to the code of the carton it came in, which is also linked to the pallet. This is all stored in the cloud database that transported from the factory to the warehouse. So pharma companies would tend to use some very well-known software providers such as TraceLink. That's a cloud database that work with manufacturers, distributors, and connect the manufacturer to the end distributor. They store the actual serial numbers. So how does serialization stop counterfeiting? Traceability guidelines from GS1, we would use GS1 standards because it's out there, very recognized, help to create a closed distribution system that monitors the movement of every drug produced in or imported into a region. As a drug moves from manufacturer to distributor to retailer and to the final patient, the product is authenticated and logged on national or WHO databases. Any suspicious activity will be flagged through these automatic verification steps and reported to relevant bodies. A set of standards is available from GS1 to communicate with the databases. End-to-end flows will show the application of barcodes by manufacturer, upload to the cloud, and authentication by the patient. And once the product has left the supply chain, it should be decommissioned, meaning its serial is no longer in use. Now, that doesn't always happen. It's one of the problems we have today, that some companies or distributors may not decommission a product. It's important because then we know that if a product is destroyed, it should be decommissioned. That means the serial number is taken out of the supply chain and it's no longer available. The benefits of implementing serialization, so the pros and cons, it gives complete security across the end-to-end supply chain if implemented well. And I can tell you over the last couple of years, so we would have, Horizon, we would have launched products in the US and abroad, but serialization in the US took a long time to be implemented. The FDA gave us a grace period of, I think, companies and distributors just weren't ready. So they gave us a grace period of a year, about 2 years ago, which was subsequently extended. And that was just to implement serialization at a manufacturing level. And now they've given us another grace period to get it through to pharmacy. Pharmacies would have to be up and running to be able to use serialization to scan barcodes when they were dispensing products. So that's about to be implemented at the other end. So it's still evolving. It needs a lot of effort across the supply chain, which I'll talk about as one of the negatives in a second. What benefits, another benefit, ensure the packs are not reused. So a product can only be scanned once. It can never be rescanned again, or it'll send a warning back to the database. Prevents falsified medicine from entering the market. It's governed by strict regulations, and enforcement is key. And I was thinking this is both a positive and a negative. If it's not properly enforced, it doesn't work. So we have to follow guidelines. In Ireland, we're monitored both by the HPRA, and we work closely with national databases as well. So you cannot distribute non-serialized products into markets where serialization governance exists. Suspicious activity will be flagged and reported through automatic verification steps. And then serialization alerts received from governing bodies must be investigated. So if we get a warning on any product, we have to go and investigate to see what happened in the supply chain. The negatives of serialization, it needs to support the whole supply chain, needs to support the whole end-to-end process with dedicated teams or assigned personnel. So for example, in our company, we would have had to train people and make sure the process is in place, make sure the barcodes are working at both ends with our distribution centers, And it does take a lot of effort and time to put it in place. And you need personnel to be working on this full time when issues arise. Enforcement must be in place to ensure regulations are followed. And again, enforcement, some regulations are different. The EMA would have different regulations to the FDA, so you have to be up to speed on the different requirements. By and large, they're the same, but there are a few nuances from country or continent to depending on where you are in the world. Pharma companies can only enforce so far. So once a product gets into a pharmacy or a hospital, it can be difficult to track thereafter. If the pharmacy decides to pass on some of the product to another pharmacy or a hospital, giving it to another hospital, a neighboring hospital, that's where, if they're not using the barcodes and decommissioning the product, we've no visibility on that. So we really only have visibility up to the actual pharmacy and once they dispense it. Another factor, data accuracy is essential. Any keystroke error can slow down the release of the product when verification steps are implemented. So this is a problem. So for example, if when a manufacturer puts an extra digit or an extra unit on a pallet, when that product eventually makes its way to a distribution center, it's scanned, and there's an error, we can spend an awful lot of time actually investigating. So it can actually slow down the release of product, but it ensures that what's on the product leaving the manufacturer, or what's on a pallet leaving the manufacturer, should be exactly what the distribution center is receiving. So this is an area I found that if you don't have what you put into the system, if it's not correct, it'll be found out at the other end, which actually is a good thing. And then third world markets may not have distributors or pharmacies that are regulated. So right now, if we have a serial code for our products going into some markets, if they don't have a process to check that the serial numbers are valid, or they don't have a barcode at the other end, it kind of defeats the purpose. It's only good for the manufacturer. Sure, yeah. Serialization, regulation, enforcement. So these are the countries: Europe, United States, Brazil, Russia. We're into over 70 countries globally. 75% of global volume is serialized. Next slide is just an overall overview of the infrastructure required for serialization. So you've got a BSO, an IT department, a serialization support team, quality team, and that's for a mid-sized company of about 2,000 people. And then the last slide, just an overview of how it works. We've got a manufacturing plant where we print the barcode. The numbers are uploaded to the database. TraceLink is the company that tends to be used. It's authenticated and consumed serial numbers in the database, and then it's dispensed at the pharmacies, hospitals, vaccines, or the wholesalers. And all of this is governed by regulation to enforce the whole process. Thank you very much.
Thanks very much. As with the other sessions, we'll hold questions to the end. So we on to the next speaker, please.
So next speaker is Karen Moniz from ICCBA. She's the technical director, and she's going to infect us with that passion I referred to yesterday, hopefully. Thank you. Thank you, Karen.
Thanks, Owen. 30 years ago, I was managing the transfusion service at George Washington University Medical Center and had my first exposure to ISBT 128. And my love for ISBT, truly, seeing the benefits of it has been tremendous. And for me to come full circle in my career and be able to work with ICCBA directly for the last 4.5 years has been fabulous. So today I'm going to talk to you about the importance of standardized terminology for medical products of human origin. Why is it important to speak the same language globally? Okay. So what does this mean? Okay. This is a petroglyph. It is located a couple miles into a trail in Palisade, Colorado. What does it mean? Okay, it's a way to communicate, right? But what does it mean? Without a definition for it, without standardization, was it dinner? Was it a pet? What's the neighboring community think it means? Does it talk about quantity? There's more than one there. But without having a defined set of definitions for what it means, we don't really know what it means. It's beautiful, but we don't know what it means. Okay. Why is standardized terminology important for medical products of human origin? Okay. First and foremost is always patient safety. Medical products of human origin carry risks, and we need to be able to know what a patient has received. And we need to be calling things the same name so that we can do statistical analysis, research, that sort of stuff, so we know what they have received. Okay. What information are we conveying to clinicians? What information are we conveying to patients? If I receive a blood product, I want to know what blood product I received, right? And if different people are calling it different things, does that mean, something different clinically? I have access to my medical records. I'm going to interpret it differently if we're not calling things the same. Okay, biovigilance. What's actually stored in the health records? I actually cut the word electronic out of this yesterday because electronic health records are important, but not everybody has an electronic health record. You might just have what's stored in your paper record. Okay, inventory control. If we're not calling the same thing the same name, how do we know that we can reach out to a neighboring community in times of crisis? That came up yesterday when we were talking about emergency preparedness in our breakout sessions. Okay. And data mining. Having the same things called the same name help us do that statistical analysis, help us do research, help us mine the data. So ISBT 128, we work off of an information environment model, okay? And you can see at the very base of this model, we have standardized terminology. Without standardized terminology, the rest of the system doesn't actually make a whole lot of sense. We still have globally unique donation identification numbering systems, that sort of thing. But the standardized terminology is key to making it all work, and it's the basis of it. Okay, so we're going to segue here a little bit. We're going to talk about how we create the product names, okay? And we don't create them in a vacuum. It's all very collaborative, but I'm going to simplify it for us here. So class names, or we have all these different areas of medical products of human origin, right? And so we have tissue, we have blood, we have cells. Well, I'm going to interject a new one called fruit. Okay, it's not a medical product of human origin, but it makes it very easy to explain it. So class names are very high-level names. And so we would have apples, okay, we can have peaches, and we can have cherries. Okay, so those would be analogous to class names. How does that relate then to what we really want to talk about is the medical products of human origin? I picked the three largest categories that we have names for, and so within blood, tissue, and cellular therapy, it's just a smattering of the class names that we have defined. Okay, convalescent plasma. So everybody calls convalescent plasma, cryoprecipitate, fibrinogen complex, fresh frozen plasma, platelets, and red blood cells. Very high level names are the class names. In tissue, we have artery brachial, vein femoral. These are just examples. The list goes on and on. Tendon, Achilles, bone chips. We have bone this, bone that. Lots of different class names there. Dermis and birth tissues. Cellular therapy. In cellular therapy, it's very regimented how the class names are called because we have what is there and how we obtained it, where did it come from. HPC by apheresis, HPC marrow, MNC apheresis, so on and so forth, iPSC skin. So just a list of a couple of the samples of what are class names within the ISBT 128 structure. Okay. Then we have attribute groups. I'm skipping modifiers because not all categories have modifiers, but just the basics here today. So attribute groups for every category of MPHO, then we have attribute groups that can help us further define what product this is. We can talk about the type of preservation. We can talk about additives. a lot of these things can reflect the safety and quality of the product. So for example, to go back to fruit, type of preservation, okay? And actually, we might have an attribute here that talked about, what we removed from the product. The pits were removed from the cherries. That's important to know, right? And so this would be a dehydrated would be the type of preservation, and you get these nice little dried cherries that you can use in really, really good biscotti. And then you can have additives, okay? In this case, we have fresh peaches, right? So that's the class name, it's peaches. And then we've added other things to it to make the final breakfast product here. And then you have other things that might be more complex. You would have additional attribute groups and attributes within those groups. And you could even have a lovely cobbler, okay? So let's back up again to medical products of human origin, blood, tissue, and cellular therapy. So we have core conditions in blood, okay? And that's always, we name the anticoagulant, we name the nominal volume, and we name the optimal storage temperature. And then there's other things that we can define. Again, this is just a short list. We can define system integrity, whether the product's been irradiated or not. That's very important to know. What's the residual leukocyte content? Has it been pathogen reduced? Okay, and that's another key safety and quality aspect. What's the antibody specificity? If you have a unit of blood and the donor has a red cell antibody, you want to be able to communicate that the residual plasma in that unit has this antibody specificity, okay? Within each attribute group, there's a list of attributes that are mutually exclusive. So you can only pick one attribute from each attribute group. And that's how the system is designed, okay? For tissue, some of the examples are, we can name the additives. We can, again, name the type of preservation. There's also pathogen reduction here. We can say whether something's been demineralized. We can talk about a nominal granule size for these bone chips and things like that. For skin, what type of fenestration was used. For cellular therapy, we again have the same core conditions that we had for blood. We can name the cryoprotectant. Was it genetically modified? Okay. Mobilization. Was the donor mobilized prior to collection? Was the product enriched? Was the product cultured? Yeah, just a short list. Okay. So how do we do this? Okay. There's not that many of us at ICCBBA. We have wonderful volunteer groups that help us, our technical advisory groups. Wayne over there is the chair of our standards committee, so we filter the requests through the technical advisory groups and then up to the standards committee. And so we also put things out for public comment when we're coming up with something really brand new data structures, that sort of thing. We put things out for public comment. All right. The syntax of what we do is quite important. This is a new slide that I'm using in almost every presentation I do now, which is implement the ISBT 128 standard as a standard. We can talk about these concepts and we can go, oh yeah, that's a nice idea and let's do it. But unless you implement the standard as a standard, you lose a lot of the benefits of the standard. There's a structured format, okay, for the linear barcodes, for the 2D data matrix symbols. We have to be able to know that the data identifiers are encoded properly so that when you scan it, your system knows that this is the donation identification number or this is the product code. Okay. We have check characters that help us with adding when we have to enter things manually. The check characters on some of the longer numbers help. Okay. Now, I didn't get really technical today. I talked about fruit, okay? But we have an hour-long webinar that we did a while back called Cracking the Code. So if you really want to learn in depth technically how product code is developed and all those things, you can go take a look at our website and look there. And I already spoke a little bit to terminology development. We have a lookup tool on our website. So if you need a code, you can look up and see if the code exists. If it doesn't exist, you can reach out to our help desk. You can submit a request. They'll help you determine, does a code exist? If we already have the classes and the attributes that would define it, that's usually a pretty quick turnaround. We publish an update to the coding every month. If it's an existing area and we need a new class name or new attributes, that takes a bit longer because then we need to engage our technical advisory groups. And sometimes we get brand new areas. Right now, we're working on a really exciting project. A couple years ago, all these requests, by the way, are user-driven. Okay, so we don't just make up all possible codes because then that would not make sense. Okay, but we're starting a project with extracellular vesicles because we got a user request. Hey, are you guys going to get involved? This is another medical product of human origin. Are you guys going to get involved? So after a period of time of emailing back and forth with different organizations, we are now collaborating with our CTCLAG group and ISCT and ISEV to start working out the process of what the class names will be for EVs, what the attribute groups will be and all that. So it's fun to kind of be in at the beginning stages of something like this. Okay. I always have to speak also about the fundamental elements of traceability. The product description code is just one piece. We have 4 of those. It's global unique donation identification number, a division identifier. You're going to take that apple and make it into slices. You need to know how many slices are there. And then we also have the processing facility code because you could collect something one place and divide it, send it 2 different places, and then they wind up making applesauce out of those apples, and you need something to distinguish those. And so that facility that's providing that final product code also adds their facility identification number on that, and that makes it very unique. We also do data structures, and so what our newest data structure is chain of identity identifier, and just very quickly, that links multiple collections that might be needed to make one product for a patient-specific product, okay? And we also have a webinar on that, so you can do a deep dive into that. And talk about bridging the gap. We have medical products of human origin. We have drug products, but they're also medical products of human origin, right? The CAR T therapy and things like that. And so that's where this chain of identity identifier comes in, because you can assign it to patient-specific therapy to every collection associated with that therapy. It means something at the beginning of the process. It means something in manufacturing. And more pharma companies are using this COI identifier on their final drug product for patient-specific therapy. So it means something at the beginning, the middle, and the end of the process. So that's kind of how we bridge that gap a little bit. It's because it's still a living product, right? Okay. And it's more than physical labeling. So it's not just what's on the bag. We can encode on the bag in linear barcodes or container. It's not all bags. I'm a blood banker. Okay. 2D data matrix symbols. Things can be encoded with RFID. And more we're doing more with electronic messaging, and that's going to be a big piece of the next talk, because you're going to hear a lot about that. All right, artificial intelligence. I was first introduced to artificial intelligence in 1968, kind of a negative way, when I heard Hal say, "I'm sorry, Dave, I can't open that pod door," or something like that. Okay, so now there's more and more about artificial intelligence, and it's coming of age, right? There's interesting things that are happening. And Owen pointed me to an article that he found on the internet about somebody looked at its usefulness in the medical arena. And the conclusion was that because of the complexity of the healthcare language, because of the medical intent that you need to understand and the clinical guidelines associated with it, they basically said AI might make coding easier, but human experts are still needed to apply judgment. So we're still going to need these structured coding systems, okay? And my key takeaways, I got the sign, key takeaways. Okay, standardized terminology can enable traceability, biovigilance, data mining, and inventory control, among other things, okay? Resources, I usually have a long list of all the standards I talked about, and I tried to avoid doing that today. All of our standards, all of our implementation guides are out there available for you to see on our website. That's www.isbt128.org. You can reach out to our help desk. You need to be registered to use the standard, but you don't need to be registered to ask us questions and learn more about it. And last but not least, I like to talk a lot about interoperability. These are my favorite trees on the planet. They're aspens, and aspens don't drop seeds, right? They go underground. They connect. Every yellow tree you see in this picture is part of one living organism. And I see that as traceability, interoperability, Everything is all connected. So if we use the same language to describe things, and it's not just the name, but it's also the carefully crafted definition that goes with it, then we can communicate and all be connected like this. So thanks.
Thanks very much, Karen. Our next speaker is Jeff Brown, who's the Managing Director of STEMsoft. Jeff's expertise is in cell therapy and cord blood banking software. And he's going to talk to us about interoperability.
Thank you. I want to start by thanking the organizers for inviting me to speak. I very much appreciate the opportunity. I debated starting this off with a big slide that said no technology won't actually save you or help you, but that probably is counter to the intent. So what I will focus on, though, is talking about interoperability. How do we get our software systems to talk to each other?
Get the technology closer.
Perfect. So I'll start with some disclosures. I am the managing director of a software company. We make software for cell therapy. So if I have a conflict of interest, it's really obvious. But that also means I have some biases that I think are relevant to the nature of my remarks. And I debated changing these slides yesterday and elected not to. I am going to change my focus, my emphasis slightly. Because what became really apparent to me yesterday is a lot of what I want to talk about is relevant to everyone in the room. But I'm coming at this specifically from a cell therapy background. So I work for and run a subspecialty software vendor. We're not a blood establishment software company. We're not an electronic health record. We're not a billion-dollar organization. We are a tiny group focused on a very specific niche. That means I see interoperability differently than Epic, if you're familiar, or Cerner, the big EMRs. It is not in their interest to talk to their competitors. It is critical for my success to be able to talk to every other piece of software I possibly can. I've been doing this for 28 years. I've been in a lot of facilities over that time, working in facilities on 6 continents, several hundred through that period of time, which means I've seen a lot of the kinds of issues that have been brought up in the last day and even this morning related to traceability and identity. I also have specific experience with regard to how we share data for MPHO. My very first, my background is as a software developer. The first thing I ever did at STEMsoft was part of the team that developed what was not just our first, but was the first electronic interface to the CIBMTR registry for transplant outcomes, which was mailing floppy disks to Milwaukee, Wisconsin. So hearing yesterday that email was a big step forward from filling out a paper form and mailing it, in 1996, we were focused on, can we mail floppy disks? We also were the first to do a commercial ISBT cell therapy label, and we were the first commercial vendor to actually connect to the NMDP system that they operate on behalf of the CIBMTR for outcome data. So I've got a lot of experience on interfaces and interoperability, but that's not my core business. So the topic I was asked to talk about was how do we get out of our silos? And it occurred to me that maybe we don't want to get out of our silos, or at least don't want to get out of them without thinking about why. So these are, I was inspired by Karen's slides to try to take my own photos. These are silos from a cement company. It's about a 10-minute walk from my home in Vancouver, Canada. They were painted by a pair of, I believe they are Brazilian artists that came in, and I think they're absolutely gorgeous. But they solve a specific problem. They make sure that material is consistent, it's uncontaminated, and it's accessible. The cement trucks can pull in underneath, load up, drive out, drive underneath my bedroom window every morning at 4 in the morning, and go about doing their business. Well, that's relevant to us when we talk about data. We want our data to be consistent. So I am absolutely picking up on Karen's remarks here. We want standardized terminology that's relevant for the current context. I didn't think to go for fruit. One thing I did think about was in this room, my suspicion is the vast majority of people in this room speak at least 2 languages, if not more than 2. And therefore are keenly aware that translating poetry is going to be wildly difficult. I speak French and English and a tiny bit of enough to order a beer in about 5 other languages. But if I get into something that's literary, I recognize I cannot translate that directly. We are choosing to, when we give our presentations here, we're choosing our language either being very, very technical, which is precise, which is specific, or we are choosing language that we are hoping is suitable for everybody in the room. And that's going to be true here as well. Describing the same event or the same object might be subtly different for the cell processing facility's batch process record, for the apheresis, birth, or other collection records, for the administration outcome records in an EMR, and then ultimately to the registry. They're going to be described differently because they're solving different problems. There is not one language that we can use that everybody on the planet will find suitable or acceptable. One of the beauties of ICCBA's terminology is it is there to solve a specific problem, and it is very good at solving that problem. The second element we want to think about is uncontaminated. Opening our silos of our data to the world carries real risk. All 3 of these events that I've got on screen are from this year. They are a tiny fraction of the number of cyber attacks that have taken place. The one that is on screen left, OneBlood, I saw a presentation at the AABB meeting in Houston a few weeks ago by the CFO, I believe it was. This was a catastrophic attack on the blood supply for Florida and Georgia in the United States. It took them, they did react remarkably quickly, but losing your computer systems is not just, well, we'll go back to paper, because you can't make phone calls. You can't send out faxes. You can't look up phone numbers, your contact lists. All of that is electronic. The one in the middle, London Drugs, this is the largest pharmacy chain in Western Canada, and they were weeks offline. And similarly, they could not make phone calls. They could not change appointments. They publicly stated they did not pay a ransom. They went through millions and millions of lines of code. I know some people that work there. This was a terrifying nightmare to go through. These are state and non-state actors. In all 3 of these cases, this was for money, but it need not necessarily be for money. The last one, St. Guy's and St. Thomas in the UK, as it lists there in the headline, they canceled 800 operations. And these were recovered relatively quickly. So opening up and making it easier to share data carries real risk. So we have to be aware of that and think about that when we talk about interoperability. But we still do want to open up because accessible data is what we need for biovigilance. It's what we need for traceable MPHO. It turns out that exactly the examples I want to use were covered in far greater detail yesterday, so I won't belabor that point. I will, however, highlight one element that struck me when I first heard about particularly the TB cases, is how long it took to trace. That this was not something, this is that when you have to go through and you have potentially recipients that are infected and their time to treatment is being extended, that's a very real problem. Again, I want to highlight, this is not my business. This is something I care about deeply, but I'm not selling you a product. I don't have anything I'm going to talk about today that's a commercial product that I can sell you. I'm going to talk purely about standards. So let's focus a little bit on data. Even within your institutions, particularly hospital-based institutions, information systems can be fragmented. I have my overly simplified version here of the apheresis department, a transplant department, and the cell processing facility being on separate software. That is almost universal, that they're on separate pieces of software. It's also incredibly common that they're actually on separate hospital networks. Thinking specifically of a group that I've worked with recently in the UK, where it was 3 separate NHS trusts. So not just 3 separate networks or 3 separate hospitals, 3 independently organized, managed organizations, one of which was covering collections, one of which was covering processing, one of which was covering transplantation. They're all physically attached. If you walk up, you think it's one hospital, but they're legally, organizationally separate. That is very common. In my own city, the BC Cancer Agency is separate and distinct from Vancouver General Hospital. BC Cancer Agency does the processing of cells, and they are separate all the way up to our provincial government. They are separate entities. They have different logins to their computers that don't talk to each other. Let's pretend we know that already. Our hospitals are fragmented. Specifically in cell therapy, and we did hear a little bit about this already, we're also dealing across multiple institutions. We need to be able to move data from, in the case of an allogeneic transplant, you've got a donor that is potentially at a different facility that is making that donation. Maybe it's being facilitated through the NMDP. Now we've added commercial products. We've got commercial products that are going to be, that may be autologous and they're going out and they're coming back. But in future, these may be more and more allogeneic products that are going out and coming back. If they're allogeneic, then they may be having some donation center. I'm working with groups right now that are setting up standalone donation facilities specifically for the intent of collecting products for further manufacturing for clinical use. In much the same way as tissue procurement might work, but facilitating that across the world. And almost every hospital I deal with is not signing up for just one commercial product. They're signing up for several. I'll add another wrinkle that has not been brought up in the discussion thus far about MPHO, which is at least for these commercial vendors, every single one of them wants to set up their own portal on the web where that hospital has to fill in data about what they did with that product. So there's a huge amount of redundant effort on the data entry. And that gets multiplied, and it gets multiplied, and it gets multiplied as we add more and more and more partners. And every one of these is going to have their own piece of software because they want the tool that works for them. Every one of them is going to need to have their own security, their own privacy elements, their own authentication elements. And then we make this wildly worse once we have to deal across different geographic boundaries. Even within the European Union, where things move very smoothly, I know from talking to a client in Slovenia that getting things from Slovenia in or out to anywhere else, talking to our clients in Ireland or in the UK is probably a bad example, moving things around gets harder and harder and harder. So what do we do about it? I appreciate that AI was brought up yesterday and again today. But I want to highlight things that on the Gartner hype curve here are focused on the slope of enlightenment and the plateau of productivity. I think AI is going to do really interesting things. I think AI classifiers are going to be really, really interesting for MPHO. I think generative AI is terrifying for this space because it's really, really difficult to, well, it's impossible to validate. It's really difficult to know what it's talking about. I would also suggest that if you were at this meeting, 6 or 7 years ago, you would have been saying, well, what about the blockchain? And when are we going to have the blockchain? That was the previous hyped technology that was going to change everything. It was going to be the ultimate traceable database. I want to focus on things we have now that are affordable, that can be implemented in any country that's represented in this room, regardless, that does not require massive necessarily investment, but that actually deliver real interoperability benefits. Okay, the first is identifiers. You heard about identifiers already. I want to highlight as a software person why the IDs make a big deal. I don't need to teach anybody anything for them to understand that this string of characters and letters represents an MPHO, whether that is the chain of identity identifier or the MPHO unique identifier. They don't need to understand it. So any software developer can make a simple search to match them. That's easy, therefore cheap. It gives me one ID to link my MPHO with my donor, my recipient. That's also easier and cheaper. I want to highlight the labels. We tend to underestimate the value of labels. They're flexible. They can go in a variety of containers. They can be low cost through commodification. But really, what's the big deal for me are the 2D barcodes, which in cell therapy are not widely adopted, and I really wish they were, for two reasons. The first is that on a label, they give us a lot more white space, which means you can print more human-readable text, which is useful for people actually working with the products, but you can still pull in the data you need. The other is that 2D barcodes are relatively data dense, and by having standards for a 2D barcode, I can print that on accompanying documentation and have a whole lot of other range of information that can be passed between software systems without those software systems ever needing to know about each other. A sneaker net, it gets carried across, it gets transported with it. The other is HL7 Fire. So HL7 Fire is the first, and I want to really emphasize this, the first standard that allows us to describe an MPHO. If you've been sitting frustrated, why does the software not do what I want? Why can't I get my data into Epic or Cerner or get data out of Epic or Cerner, et cetera? It's because there was no description of an MPHO available before. This is huge. It's also huge because this standard does not require specialist knowledge or tools. It relies on open technologies, so REST, HTTP actions, XML, JSON, and OAuth, W3C data types. What all of that means is I can hire someone straight out of school and they can start working with this. There are free and open source tools that are available. So whether you're in Canada or you're in Kenya, you can work with this technology right now. There is no additional cost involved. It's modern. It was designed in the era of cloud and mobile and Internet of Things. What that means is it's designed to be distributed. It's not a hub and spoke model where we have to carefully negotiate and plan things out and have everything to talk to each other. It's designed for flexible architectures. So all of those dots on my map of Middle Earth can each have their own Fire portal and be communicating with each other without having to have some central negotiation. It can also work for your governments, but it can also work for the individuals. And last but not least, it is implementer focused. So it's using common web technologies that, again, I can get free tools to work on this. I can find people anywhere in the world that know how to use this technology. It's already supported by the big public cloud providers, so Amazon Web Services, Microsoft Azure, Salesforce.com, SAP. I recently learned that SAP's integration engine. So for those coming from the pharmaceutical world that maybe are using SAP in the back end, I know we have a partner that's doing this now. We're integrating MPHO data back for a billing interface. As I say, there's multiple toolkits available. There's a free Microsoft implementation that actually is what we've built into our product. We didn't build this. We took the Microsoft implementation, it's licensed to allow us to do that, and we've integrated it as our engine. So this is that first standard. And the reason this is important, it is a Lego block. It doesn't have to describe everything. It just describes the MPHO itself, and you already have in Fire the concept of a person, a subject, so a donor, a recipient. You've already got observations, those are test results. That's the volume, that's a CD34 count, that's every other attribute. You have a service request, you have these other concepts that are already in existence and well supported. And it already supports the MPHO unique identifier in the COI today. I am completely enamored with this. I think we have it in production use at a whole lot of different facilities now. We're seeing production use being in a whole lot of different environments, in a whole lot of different industries. The last concept that I want to highlight, and again, it's from an IT point of view, is a Fire profile. So Fire profile is where you state, okay, we're going to take these resources, these Lego blocks, and we're going to assemble them into something that we can now use. And so that Fire profile, that could be the biopharma companies, all the CAR T companies could agree, let's have a common Fire profile, so your IT people only need to build one thing for all the CAR T. Or if you're building a registry for your region, you can have a fire profile. And that fire profile is beneficial because it's computable. In other words, it's not an agreement or contract that is describing whether or not you've met the specification. It is something that we know or do not know programmatically. We can tell immediately, did we build this the way it's supposed to be built to be able to talk to each other? Which means it can be validated. And because these profiles are public, we can see what other people have done. We may not need to invent anything. There is a project going on right now for the US Department of Defense building a distributed electronic health record. And they started working, this was presented at a fire conference recently, they started working on this and they needed a fire profile. And they started thinking we're going to have to make our own. And then they discovered a group in Canada had already developed one, and it was good enough for what they needed, so they just adopted it and moved on. That reduces cost, it reduces time to market. So we can reuse these things. We can take our Lego blocks, assemble them together, and have specific profiles for MPHO. I'm going to emphasize that one of the reasons it gets frustrating with your IT departments, it gets frustrating with your software vendors, is it's not in their best interest to interoperate once they're over a certain size. So this kind of free and open source tool is really beneficial because it allows small players like Semsoft, or it allows countries, developing countries, to build tools and technologies that are suited for their unique environment and then interoperate elsewhere. But that means we do need you. We do need you to talk to your governments and say, we need to make this happen. I've listed the US CDI here, largely because that's what will influence EPIC and Cerner and the big EMRs. But I will highlight my new Apple iPhone has a USB-C cable purely because the European Union said you have to do this. Apple was never going to go away from proprietary cables. No one is going to go away from proprietary unless they're either made to or there is an overwhelming commercial need. You can make that overwhelming commercial need by demanding profiles like this be available and making sure that they're in the software you're using, asking for them from your vendors now so that you can start talking to other people. Thank you.
If we could get the speakers to come to the podium, the chairs for a panel discussion, please.
We are going to keep you from the coffee for just another few minutes because we had, of course, a late start due to the bus arriving. So if you can just bear with us, please.
Okay, hello, hi. I'm over here, Kelly from Ghent, IVF World. Fascinating talks. I have a question. I don't know who is going to answer, or maybe you all can answer it. What I see in our hospital is that cloud-based systems are often looked at as being, oh no, not the way to go, because I mean, you know, dangerous and we will get attacks and have you never heard of blah, blah, blah. So as an end user, it's often very difficult to explain to our hospital that, yeah, I mean, you know, this is a cloud-based system and we really want to use it, and it can connect to EMR via HL7 and things like that. So can you, from a technical point of view, explain why hospitals are so reluctant to do that? Is it because it's about patient data getting out there somewhere unprotected, or are the protections in cloud-based technical aspects not as robust as on servers? I mean, can you explain to a non-IT girl what the real issue is? Because I never get an answer that is satisfying to myself if I ask that to our ICT department.
I will try to answer that. The answer, to a certain extent, depends on your jurisdiction. Legally, from the work I've done, it is almost impossible to get data out of a hospital in Germany. In the US, just walk out with it, it's fine. What we're seeing in the US is massive adoption of cloud. And the reason in the US it's being done, it's as my former boss put it, it's one throat to choke. It's not that it's safer, better, faster. It's one contract, and it's not my problem. It's not my fault that things went wrong. It's their fault because they've got the contract to do it. I would argue that those public cloud providers are as good or better than most hospital IT departments. And I'm going to say that because it's that they have a scale that they can hire specialists to focus on the kinds of cybersecurity problems that we're facing that a smaller hospital will just never have the scale to do. The other challenge, though, is it does make everything very public. And so you have to, the privacy is a very real concern. I'm currently of the view, I don't think, we've moved all of our in-house things. Like I have nothing physical anymore. Everything for my company is in the cloud. And we did that actually for security reasons and disaster recovery. We live in an earthquake zone. So we wanted things that up to a certain point, we could, you know, survive a natural disaster and not be physically affected. That's beneficial, but the privacy concerns are very real.
Yeah, I'd probably add that, like to use my organisation as an example, Australian Red Cross Lifeblood is a national blood service of Australia. 90% of our workloads run in public cloud, either in AWS or Azure. But convincing people that that's the right thing to do, the safe thing to do, does take quite a bit of work. And my interactions with hospitals in general are they've built the castle walls, they've pulled up the drawbridge, they've filled the moat so they're safe, and going to cloud, then they've got to drop the drawbridge to go to cloud and it makes them uncomfortable. But you know, I would agree, the investment that commercial public cloud providers can make in security completely dwarfs anything that any private or public institution could possibly do. So they are as safe as houses if they're configured properly. So that's, I don't know whether that helps or not.
My question is for Jeffrey. So we're working with about 45 pharmaceutical companies. And like you said, each one of them has their own portal. And we are entering data into each one of those portals. How do you envision HL7 Fire helping with all this? They're not going to be wanting to share data. We use Epic as the hospital EMR. What do you envision HL7 can do for that, for this situation?
So I think there's two things that would need to happen for this to help. The first is those pharmaceutical companies understand that this is cheaper for them. That's the big one. They'll spend less money, which they'll probably like.
How do you make these people understand all this?
So what I'm trying to do right now, and again, it's not, I have no commercial interest, well, I have kind of a commercial interest. If I can get this to happen, I will make a product to go with it. But what, at the ABB meeting, I was talking with Lee Buckler from America's Blood Bank, and what I'd like to see is, can we get, there's a consortium of these biopharma. Can we get that consortium to agree, here is the standard we will use for data interchange? Because they don't want you to have to do manual labor. They know you don't want to do that. And they don't want to have to validate the data you're typing in. The actual hard part's Epic, because Epic does not want to talk to other systems if it can help it. They want you to buy more Epic. But that said, Epic has a significant investment in Fire. That's the first thing.
Just explain who Epic is.
Oh, sorry, apologize. So Epic is an American, privately held American electronic medical record software. They are by far the biggest provider of that kind of technology in the United States. They are selling an increasing amount in the UK and elsewhere in Europe. So they're all over the place. What makes them and this is my own sort of barely informed opinion, what makes them vulnerable is they've taken billions of dollars of US federal government money for electronic records, and therefore they have to maintain interoperability standards. So getting the US federal government, that US CDI that I put up, getting MPHO and the US CDI means Epic will support it. They have to. Like not have to as in it's in their interest. They are legally required to. And so if they are legally required to, then that gets you the infrastructure that your hospital IT can use to plug these things together. And if you combine that with the consortium agreeing on a profile, then you only have to build it once and use it all over the place. That would be my dream.
Hope it comes true.
Yep, thank you. I was amazed by one of the slides from Finton, actually, where you have substandard and falsified medicines. So we do not have that kind of definition, perhaps, in MPHO, although we do have sometimes, does that product meet the quality requirements? So that will be fitting into the substandard, more or less, although that does not apply to all the products. So the question is like, in the medicines, you have an NRA, a National Regulatory Agencies. So what is the equivalent in MPHO? We have a mess of products, but we also have a mess of regulators and of competent authorities, and who has actually the oversight. And even what we've seen, the cases in tissues, for instance, in America, a multiple number of agencies were involved. But who has the final responsibility? And that's a question, I mean, or maybe a statement or something to reflect on for everyone, especially maybe links back to the standards, because we have a clearly defined language, but then we do not have someone to actually monitor or implement that. So we do have, now that the question is more or less, would the medicines agencies, which is well-established institutions, will be eager or relevant to take the responsibility of monitoring also the MPHO as a subcategory of the medicines or health products. I know people don't want to call it medicines. But we see also some resistance from the established, let's say, competent authorities to let go. Again, I'm provoking, but I think something that we have to reflect on to who will have the final responsibility, because this is on a public health trust.
Well, I'm just going to say right now, it's a huge potpourri of different agencies. There is no final word. ISBT 128 is a global standard, but yet we are implemented in fewer than 80 countries. So we don't encompass the whole globe, and there are no regulatory, and some countries are regulatory requirements to follow the standard, but most places are not. And so one of the reasons I'm so passionate about the standard is that I firmly believe, and have seen the benefits of implementing in blood, that it is the right thing to do. However, a lot of people don't do things just because it's the right thing to do. They've already got a system in place. The cost of implementing is high, but I wish there was a final word, okay? But I don't see that, but I think it's a valuable discussion.
So one thing, okay, so I think everyone here is convinced that ISBT 128 is great. It does what it's supposed to do for medical products of human origin, but healthcare facilities may not feel that way because they look at the most common thing they look at, which is GS1. And GS1 does most of the things that they want to do. So what I want clarification from the panel about is how ICCBA is working with GS1, and is there an understanding, or what is the education of facilities to make sure they understand why ISBT 128 works better for medical products of human origin than GS1 or other coding systems?
First of all, we have Martin. I don't see him now, though. Martin Fitzgerald from GS1 is around. I think I could try and give a very short answer. We talk to each other. We have an MOU with them since 2012. We have joint publications on how to package with GS1 container MPHO labeled with ISBT 128. So there's been a tremendous amount of work done to make those systems complement each other, and we expect that relationship to continue. Now, we have Elisabetta and we have Maria from what I would call industry groups, whether it's ARM or Bioforum, who may have something to say as well. But I want to bring in, sorry, because Yap-Yan was there first, but it might be part of the coffee conversation as well. I think GS1 is the package, and we say what exactly is in that bag with all of the detail that Karen explained. That's probably a simplification, but I think it'll serve. Yap-Yan?
Yeah, I'm a physician, so I'm sometimes at a loss when data people start to talk. But traceability often starts not with Epic or other patient information system. It starts with an inventory software, and then there's a transportation software, and then it's a laboratory information, medical system, etc. Is FHIR, is that going to solve the communication, transportation, etc., and traceability of these products throughout these different data systems?
Solve is a big word. So what it addresses, why it is different from previous standards, aside from specifically including MPHO, is that it took the same technology that's used by Google and Facebook and your bank to do things on the internet. So it did not try to invent a new security model. It took the one that already existed. It did not try to invent a new authentication model. You are who you say you are. It took one that was already being used on the web. It did not try to invent a new authorization model. What are you allowed to do? Took the one off the web. Everything that is why I think it's brilliant, because it took the stuff that everybody was already using that was mature and very well supported. And as I say, that means there's a lot of tools available to support it. What it then further does, that profile idea, that computable profile, is a big deal, because what it's allowing is for you to then define for your industry or your problem, here's the set of pieces, the set of Lego blocks that need to be assembled together to solve this particular problem. And that is very different from previous data interchange standards, where those data interchange standards previously tried to innovate all of it at once, and often in HL7 version 2, the one that almost everybody uses, the same content is represented 2 different ways, or 3 or 4 or 30 different ways, depending on the context. And that's where it gets really expensive and hard to maintain and support. And because this is designed to be distributed, it's well suited to your example of the logistics company, can invest in supporting this. The fact that Salesforce and SAP, those are nowhere near healthcare at all. Salesforce, for those that don't know, it's a customer relationship management system. We use it to track customers. SAP, a enterprise resource planning system, big, manufacturing system. They support it. That's what's interesting to me, because it means all of these other players can, at relatively low cost, participate in a healthcare context.
I'm going to jump in with that.
Probably I will be in line with you in the coffee.
Sure. So question for you first, maybe. When you say you have integrated FHIR in your software, did you do profiling for biologically derived product? And if yes, is it available on the registry, FHIR registry, for anyone to refer? Or is it that you refer to any existing profiles from any existing work groups? And second is which exchange paradigm you utilized from FHIR? Is it complete API, or it's just the profile and your own API? And did you try to do interoperability with any existing or other softwares other than your own platform with the same profiles?
I fear the answer might be long. Yes.
interesting.
No problem, no problem. I'll catch up with him. Yes. And one question for Moniz, maybe. Just one question. That also you can answer later, no problem. So you were explaining about the classes, attributes, and definitions. Do you have a defined ontological model for data definitions? And if yes, which are the different approaches that you use, open world, closed world approach of defining data elements? So you can answer later, no problem.
Take it to the coffee break.
I think so.
Coffee.
Thank you very much for everybody, and thank you for our speakers. And we're about 20 minutes behind, so if you can come back in 15, I know there'll be a long queue for coffee, but if you can come back in as soon as you can, please. Not with your coffee, I understand, but no food or drink or that.
Hello, welcome back. Thank you, everyone. My name is Kathleen Hopping. I am the Senior Director of Regulatory Affairs for Vitalant, and I also serve as the Chair of the America's Technical Advisory Group for ICCBA, and I serve on the ICCBA Board of Directors.
And my name is Martin Hildebrand. I'm from Munich, Germany. I'm at the Technical University Medical School, and in charge of cell manufacturing, T-cell programs. And I've been on the ICCBA board for 6 years, going before Kathleen came, unfortunately, but we're still collaborating, as you see. And I'm in charge of the Technical Advisory Group for Regenerative Medicines. And now I hand over back to you.
Thank you all for attending the session today. Today's session, we are projecting into the future, and we have 3 fabulous speakers for you today. Our first speaker is Dr. Joaquim Vives, and he will be coming up to the microphone. Thank you.
Thank you so much for the invitation. Owen asked me, well, this is a challenge to, I think that the right words were a science-based imagination and down-to-earth challenges. So I'll try to do that, and I hope that you will help me. Let's start with my first slide. We saw today different numbers, but the idea is there. We know that from one ideal eligible donor, it's possible to recycle, if you allow me to use this word, many organs and tissues. So you understand the value and the potential of this. And what I'm trying to talk today is what else we can do in order to personalize medicine, in order to make sure that the patient receive exactly what they need, not only as an act of transfusion or transplantation, but actually, shaping these medicines into something that could be more relevant and more personalized. I summarized this in this slide. I know that it's a very simple classification, and we talk a lot about this yesterday and today, but I wanted to highlight a couple of things. One is the extracellular vesicles. We heard about that today. The other thing is the concept of manipulation, substantial manipulation or minimal manipulation. And another thing that I really like from here is the possibility of combining any of these elements in order to add complexity to the medicines and also to shape it to what are the requirements in the patients. Here you see technologies that maybe we will hear more about in the next 20 years. One of them is 3D bioprinting. There is a colleague of mine at the Blood and Tissue Bank that he always says that the tissue bank of the future, it won't be just the tissues, it will be maybe a fridge or a freezer, and there will be bio-inks, so you could bioprint whatever tissue that is required. I don't know whether that will happen in the next 20 years. Maybe not for all the different tissues, but definitely some of them could actually be produced in that manner. And another thing that is quite interesting from this slide is also the possibility of maturing these tissues. If we combine these scaffolds with cells, it may not be sufficient just as it is. Actually, maybe we will need them to grow in the lab and to make sure that the cell types are the ones that we are interested in. And of course, this requires this traceability that is all this meeting about. So especially when we are combining tissues from one donor, cells from another one, also maybe extracellular vesicles from another one. So you see that the complexity is actually in all different levels, and that's something we need to bear in mind. In order to address this, actually, we conducted an exercise. Some of, I would say, the main blood and tissue banks in Europe, for instance, with the Sanquin in the Netherlands, with the Irish Transfusion Service, with the Finnish Red Cross, and of course the Blood and Tissue Bank in Barcelona, and several other partners. And we proposed this model, this management model, that it works quite well, let's say individually. Yesterday we talked about the fragmentation, but our idea is that this actually could be done in a European level. So if we put together this infrastructure, knowledge, ambition, and also the different lines of activity. You see here that I mentioned SOHO donation and processing, but also the development of these innovative therapies, and of course, diagnostics and safety. If we do it at the European level, maybe we could offer more solutions to the patients and facilitate patient access. I will go more in detail to that later, but I just wanted to show you this. It was published last year. So and is open access. So I recommend you to have a look. And now let's come to my lab. This picture is actually 2 years ago, and you can see Maribel at the end of the picture. She's handling a bioreactor. So we are currently using bioreactors. We use them for the expansion of cells, not only for using cells as such, but also to use the extracellular vesicles. We are currently developing a project in which we expect to use them in the context of myocardial infarction. And you see here Laura using a Prodigy. That's probably something you are, most of you are aware. So this is a machine that automates some of the processes. We use them at that time for the production of virus-specific T cells. My colleagues use it currently for the production of CAR T cells. There are many different other technologies. But as you see, 2 years ago, we were already into these kind of devices. And now that I mentioned the CAR Ts, you're probably more familiar with this methodology. The procedure actually requires, the apheresis from the patient, so that these therapies are autologous. But the logistics are very complex. It takes time, and there is the risk that the patient will not be there when the product is ready. And it's not science fiction, actually. It's possible to do it in vivo. I think it was last month that it was published that the very first patient was enrolled in this clinical trial to test whether in vivo CAR Ts could actually be safe and efficacious. And this is not the only one. There is a list here of several different clinical trials, several companies that are pursuing this objective. And this is important for different reasons. One, of course, is that we will reduce the time that we will have the CAR Ts ready in the body in this case, because it's in vivo, but also reducing the costs. You probably are aware of the prices of the CAR Ts. This could reduce into orders of magnitude the price of the CAR T therapy. So I think this is really a win-win for everybody and facilitating the patient access. I'm sure that we will listen a lot about this in the coming years. Another thing that I wanted to highlight is this technology that allows us to reprogram cells. We know a lot about this. It was first published in 2006, and since then it's been proved that actually this is a reproducible methodology. Some clinical trials actually are ongoing. Only last week it was published the results from the macular degeneration trial. So this is quite encouraging, but at the same time, it's very complex because the original methodology actually is providing methods in order to rejuvenate any adult specialized cell into a pluripotent state, and then you have to differentiate those cells into the cell type of interest. But of course, you can imagine that there is a lot of risk there. There's a lot of quality control, and it takes time, money. But there are other alternatives to that. It's possible maybe to trans-differentiate into, let's say, more similar cell type. And actually, I wanted to show you from that paper on the top that there is like a guide of which are the genes that need to be switched on in order to transdifferentiate a given cell, like a fibroblast, into a cardiomyocyte or neural cell or whatever. So I think that we will listen a lot about that in the coming years. And again, if we put it together with what I said in my previous slide, maybe, perhaps, there would be the possibility to doing that in vivo. Actually, there is some evidence in mice, not very encouraging yet, but well, we'll see. Maybe the results from the CAR-T therapy in vivo will actually support the advancement of this technology. And another point that I think that is interesting, and there is a lot of interest from the regulatory authorities, is actually to reduce the animal testing. And here we have a huge opportunity in using almost everything that I said before, apart, of course, of using tissues directly from the donors, and create this kind of human on a chip using microfluidics, and then testing new drugs in these kind of devices. So again, this could maybe reduce the animal testing at the same time that maybe it could also help for the planning of clinical trials. This combined with artificial intelligence, with let's say in silico trials, probably will help us to advance much quicker and cheaper than we do it today. Also ethically, let's say more better. That was my first part of the talk, and the second part maybe is a bit more boring, but I try to capture here the other part of the challenge that Owen asked me. So the first one was about, of course, these technologies for the coming years, but the second part is now going down to earth. What are the challenges? And I actually was a bit lame. I used this paper that we published this year. This was an exercise because I'm a member of the EU task force for the International Society of the Cell and Gene Therapy, together with Jeb Zwajinka, that is here in the audience. And we performed this exercise together with the European Blood and Marrow Transplantation Society, and we published this paper that is open access. And basically what I did is that from this exercise, from these discussions, I'm going to present these 8 moonshots. And of course, there are some challenges associated to that. The first one is the need to establish a data ecosystem. The proposal is to create a comprehensive, unified data ecosystem that captures real-world data from all ATMP applications across Europe, beyond what is already existing, like the hematologic and bone marrow therapies. Of course, it has some challenges, privacy, ethics, security concern, who is actually funding this. But this is something that is quite necessary, and I think that discussing with some of you, we agree on that. The second moonshot has to do with the harmonization of quality standards. I think that we also heard about that quite a lot today. And basically we propose to develop a European-wide framework for ATMP production that aligns quality, safety, and efficacy standards between the commercial that we already know what is required and the hospital exemption, because we know how different are the laws in the different countries of Europe. But we understand that if that is done correctly, it will facilitate the production of locally manufactured point-of-care therapies under these same stringent criteria. The third moonshot, it relates to the implementation of reimbursement models. I don't know if you're aware of that, but the EMA has authorized 27, I think, ATMPs in Europe, but they are only reimbursed 7 in Spain. So what happens with the rest? I mean, this is a potential solution for patients, but there is no access in the public health system. So we propose to develop and adopt a European-wide outcome-based reimbursement. So it has to do with the efficacy of the therapies, ensuring equitable access to ATMPs regardless of a patient's location. This model would incentivize results because the companies will try to develop better ATMPs, paying manufacturers based on the outcomes and health improvements. There are some examples of that ongoing at the moment. The fourth moonshot has to do with the academic collaborative networks. We mentioned that yesterday. There are several in Europe, but it again is fragmented, and we need actually to talk together. Basically, establishing a robust network of academic and clinical centers across Europe, capable of producing CAR T cells and other cellular therapies. And this network would allow for point-of-care manufacturing, reducing costs, and expanding patient access to therapies. I'm going to give you one example. We have a very close relationship with the Finnish Red Cross, and if it would not be because we know each other, we don't even know which are the compassionate uses or the hospital exemptions in Finland, unless that they publish a paper. So, but on the other side, the Spanish regulatory authorities, they publish in the website what are the authorized hospital exemptions. So these different criteria make it very difficult for researchers, for clinicians, and for patients to know what therapies are actually available. The Moonshot 5, it has to do with public-private partnerships. This is a must. I mean, we will not advance in this field unless there is a collaboration between public and private. But of course, there are different interests, and we need to overcome that. So we propose to establish a consortia that bridge the gap. I know that we repeat that in every meeting, but we really need to bridge this gap between academia, industry, and regulatory bodies. I think that this is something that was mentioned yesterday. We need the governments and we need the regulatory bodies to take part of this consortia to fast-track ATMP development and approval. So these partnerships would pool resources, share intellectual property rights, and optimize early-stage research funding to expedite therapy pipelines. The number 6, I told you there are 8, so 3 more, is to create a workforce training program. We will not succeed unless we have the right professionals with the right knowledge that is required. And this is very innovative. So even if we recycle stuff from progenitor transplantation or from tissue banks, they really need this training, these competences. So we propose to launch a pan-European training program for professionals in gene and cell therapy, spanning preclinical research, clinical trials, regulatory science, and advanced manufacturing. So this program would address the critical shortage of trained professionals and provide equitable access to high-quality education across Europe. We are trying to do that in the Netherlands, in Spain. We have a joint master program that tries to cover this, but again, it's limited. We need more effort on these kind of initiatives. Number 7 is about public awareness and regulatory action. This is so important because, well, we propose to develop a Europe-wide initiative to educate patients. We want to educate the society in general, but of course patients in particular, and on the risks of unproven cellular therapies. There are examples every day of private clinics offering unproven therapies. I think it was last month, I heard an advertisement on the radio in Spain. So this is happening every day, everywhere. And we have to be careful because maybe the regulatory authorities, they cannot actually chase everybody. We know the FDA warning letters in the US, but this is happening here. So careful about that. And of course, the patients have to understand what is the clinical trial, the possibility of a placebo or maybe a different dose of the experimental drug. I know that there is a very good work done by the ethics committee and the sponsors of the clinical trials, but I think that we need a little bit more. And finally, the moonshot number 8 is about improving accessibility and innovation. We propose to revamp European ATMP regulations to simplify the authorization processes. There's a lot of paperwork. I know that the regulatory authorities in Europe are actually doing a great job. If you go to the website now, the information is easy to understand, although there is a lot of information. There was a STARS program also to educate on regulatory aspects to the professionals that are developing ATMPs. But that's something that you cannot do once. You have to do it every day, constantly. So this will support rapid patient access while maintaining the rigorous safety standards. There are different models. We need to refine ours. This includes these guidelines for hospital exemption. We see this as an option, and enabling faster pathways for high-need patient populations. It could be like conditional authorizations, like happen in Japan, for instance. So there are lots of different models. So with this, just a couple of final remarks. I think that this moonshots represent critical pathways to overcoming the obstacles facing cellular and gene therapy technologies in Europe. And we focus mostly on infrastructure, harmonization, equity, and education. So with this, maybe Europe could lead globally in ATMP accessibility and innovation, creating transformative therapies for diseases with high unmet medical needs. And with this, I will finish my talk, but before that, if you are interested in what we're doing at the Blood and Tissue Bank, I invite you to watch this video on YouTube that is very short and very clear, I hope. Thank you so much.
Thank you, Dr. Vives. Excellent presentation.
Like in the previous sessions, we will save the questions for the aftermath. And I would now like to invite our next speaker, Vanja Nikolic-Markic here from the EDQM. And I'm very grateful that you're here with us, especially because when we think about the products of the future, which may be the fun part of the entire meeting, we can be concerned at the same time because we have to establish the rules for the starting materials now to be able to manufacture consistently in the future. And I'm very curious to hear what you, coming from EDQM, are planning to build the platform for the future. Thank you for being with us.
Yeah, thank you. I would like to thank to organizer for this invite to give this very super difficult, probably the most difficult presentation in my last 20 years. So yeah, been thinking a lot, and thank you for BST colleagues and friends always giving me as a former inspector and regulator, and now again kind of person in charge of standards, giving me more and more headaches, especially after this presentation, how we are going to deal. It's difficult for a regulator to think how we are going to deal with things like in a 5 years time frame. So first I will, no, what have I done? Oh, this one. So I will first inform you a little bit how we operate nowadays. So this is EDQM. For those who are not very familiar, we are agency of Council of Europe, formerly known as Pharmacopoeia, enlarged of course. We are not nowadays from 60s. We are not dealing only with Pharmacopoeia, but also SOHOs and other issues of problems, if you want to call them, of quality in medicines and healthcare. So we are not EU agencies. Council of Europe is much bigger. It is 46 member states, and 27 of EU member states are also members of Council of Europe. And as here you can see our portfolio, what we are dealing with, and substances of human origin, that is MPHO in WHO terminology. We are dealing with that. It's nowadays it's like around 20 people team, and we are growing because everything around us is growing as well. So this is how we are doing nowadays. So we have 2 committees. As you can see, this is already kind of how to say, historical. One is Committee for Transfusion, CDPTS, and the other one is CDPTO, taking care about organs and tissues and cells. We heard from Martin about this historical connection between organ donation and tissues and cell donation, so you can see also part of the historical thinking here. We still have this situation, organs and tissues together, and yes, it is getting more and more complex to deal with that. Our Committee for Transfusion is around 40 members, but for organs and tissues we have already almost 100 people. So you can imagine it's quite difficult to reach consensus on difficult questions. So we, of course, operate as a whole Council of Europe, human rights and all things that we are attached to on non-commercialization, of SOHOs, mutual assistance and protection of donors and recipients as well. So probably our most prominent publications are standards for tissues, organs, and blood. I don't know how many of you are familiar or using those. They were mentioned yesterday and today. So here they are. We started with blood in 1992, so it's already quite a nice history. Then in 22, organs started. So first tissues were with organs in the same book, but that book, I remember, second edition was around 100 pages altogether, organs and tissues. And then we separated tissues in 2013, and now only tissues are almost 1,000 pages. An edition that we are working right now on, it will be even more, but thankfully it will be digitalized. We won't be printing books anymore, hopefully, because it's absolutely not manageable. And this is how it looks nowadays, how it looks cycle of revision. As you can see, it's around 2 to 3 years, because it's quite an enormous job to have complete revision of something that is 1,000 pages long. So we have different members group of distinguished members. They are usually nominated by their countries, but also CVs are assessed, and they are then selected based on their expertise. So then the revision process starts, and I can tell you it is very, very difficult. It requires enormous organizational efforts to put all those people together, to have all those discussions, and to finally reach something that we hope it is best practice picture. Even copy editing is enormous, you can imagine. So we are struggling with translators, for example. We don't have enough translators to do that on time, because if it takes a year or something to do proofreadings, to do editing, and to translate in the different languages, at that time it is already obsolete. Then we do have stakeholder consultation that also lasts a certain amount of time, and it's never enough, because there are always some comments that are coming after the closing, and people, oh, but we didn't have enough time. Of course, you don't have enough time to read 1,000 pages. But even this is too long, because it really delays publication. And again, we are struggling with that issue of not being obsolete. Then it needs to be adopted, then it is a final editing, and then finally publication. So it takes around 3 years. And by that time, we are already starting to do new revision. So this is how it looks now. And here you can see how our work groups look, how they are chosen, how stakeholder consultation looks. So you can check it later. It's a little bit dry. And now we come to this. So you can see my organization is not supporting me in my imagination. So this thing surprised me as well, because we all know that, yes, knowledge is growing every day while we're speaking. Many things are already history in the moment, but I was surprised finding this. I have to admit that my estimation was somewhere between 1988 and now. So I thought, let's maybe like 5 years, kind of, but every 12 hours, that's serious. And somebody mentioned today also Nobel Prize. So just to give more, how to say, acknowledgement to this estimation of doubling of knowledge. There were 2 Nobel Prizes this year awarded to fields that could be connected to our work. One for physiology and medicine. As you can see, those poor MIT guys. So that's maybe good advice for parents if you want your kid to go to be something. Distinguished scientists definitely should go to MIT. You see they're both from there. So it took them, they waited for 30 years. And that's more or less, if you check physiology and medicine, that's more or less time period that you have to wait. So many of people, we are also aware, did not even live long enough to to live this, to be recognized and acknowledged. But another one in chemistry that is also very, very close with what we are doing, or maybe what will close our work, is this one. And you see, it took only 4 years. So it's not it's not kind of breakthrough. We know there are only 20 amino acids to create proteins. So we know that for ages, that wasn't a big deal. But how they are folded in 3D dimension, that was actually the science. So we were not able to create anything because we did not understand how those amino acids to create connections between themselves and what is limited factors. And they did it. And the first protein that they created successfully, it was only in 2020. So after 4 years, only 4 years, it is already awarded by the Nobel Prize. So if we still consider Nobel Prize as something relevant, this really shows that this situation with enormous growth of the knowledge is not just confabulation. So that's why I think this won't be popular, but I think that we won't be relevant in the 20 years. I know that I won't be, definitely not as a regulator, and I don't envy those people who will be in that role because it will be really, really difficult. Why? Because first of all, I think there will be other treatment products developed, not needing anything from humans, not needing human body parts. And as a medical doctor, I was always taught what we need to do is actually etiological treatment. So treat what caused your condition, not what is the symptom. So also hope is that this will happen. So we will be able, especially with genetics, but also other things that I cannot even think about, we will be probably able to treat things right in course, and then it will stay really, really little. I know that nobody likes that, but probably those products and everything will be safer, cheaper, easier to obtain, easier maybe to transport or something. I have no ideas. But for those who will survive, if we will still be there, somebody will be working, and if anything stays same as it today, so yeah, we will have to deal. This is what we are facing right now also in EGQM with scientific development and growth, how we are going to do, not in 20 years, but in the next 3 years. So definitely it is growing. So blood more or less and organs are more or less stable. Those are old SOHOs, not many will change. Tissues and cells, something different. But what we call gray zone, so between ATMP and classical tissues, and especially classical cells, probably this field, so-called gray zone, but shouldn't be, as a regulator said, it shouldn't be, shall not be gray zone, this will grow enormously, and we will have to deal with that. So there will be technical challenges connected to that. What are we going to recommend? What we are going to put as a standard? There will be ethical challenges as well, enormous. EGQM and Council of Europe also dealing with that, and not only about technicalities. And there will be legal challenges. When you have something that is ethical, there is always legal going together. So we can issue for ethical challenges, we can issue recommendations, opinions, positions, but they will always have to be connected, those things, also with regulatory mechanisms, national mechanisms, but we were talking also a lot about harmonization. So supranational, probably yes, maybe Council of Europe is also doing something like that. You're all familiar with different kinds of conventions, like the latest one was Convention Against Organ Trafficking. So, but are they strong enough to really put some, to give an impact on the field? We don't know. We'll have to see what will be behind everything. And then technical standards. So after you solve everything, so with technicalities we start with, but then you cannot recommend anything. You can't say this is technical standard unless you solve all other issues. You cannot leave open ethical issues and say, yeah, you should do that without knowing what is behind. So we will try to deal with all those things. And that will, of course, put a lot of challenges. So first of all, this is what we are facing already. We have so many great experts. They are experts in one cell, part of the cell, not only like tissues, all together tissue or organ experts, but really so one of the principles of the medicine is holistic approach. We are definitely going to lose that. One person is talking about part of the cell and another one is talking about another cell or another part of the cell, and then we have tissue and then we have organ, and we have our patient who needs everything. Who is going to deal with the patient? How we are going to harmonize all those ideas? If you pay your attention to one thing, maybe you will destroy other thing. I remember when I started as a transplant coordinator a long time ago. I'm an old person. So I remember we were always fighting in an operation theater, who is going first to retrieve what. Of course, cardiac, we have to go first because there is a shortest time frame you can retrieve heart. Yes, but in the meantime, if perfusion was not very good, then kidneys are destroyed. Yes, but we need kidneys because demand for kidneys is higher than demand for heart. Yes, but your patient is not dying and our patients die. So who is going to say who's going first? We don't have operation room anymore, but it is definitely theater. So complexity. I don't know. I don't think I can say it's going to be difficult. It is complex already. How we are going to set a framework, not something final that you will have to follow, but really at least a bigger frame. And how to achieve consensus. There are already difficulties in achieving consensus in very simple things. How we are going to deal with those difficulties when not everybody will be able to really have an overview about everything. Another problem. And then overflow of scientific publication. We hope we are right now implementing some measure to try to deal with this, and it is already difficult. Publications are growing. There are hundreds, thousands. There are under publications, I don't know what would be the word. Okay, so people are not publishing a lot in some parts of our field, but then publishing enormously a lot in other parts. So what is relevant? Is it by impact of journal? Is it, so we will have to deal, we are now dealing with that, and we will have to deal even more. So if we don't deal with these challenges, we might result in something that will simply not be useful. And even worse, contradictory and wrong. So how can we deal with that? So this is really just contemplation. We have our intergovernmental committees. Will they be there in 20 years? I don't know. Let's pretend they will. So they will have to definitely have more proactive approach, horizon scanning. Nowadays it is called foresight. That's more fancy word, but whatever, it will have to be proactive. For that, of course, they will have to be experts. They will have also to organize more, or we will have to organize, but they will have to conduct and coordinate more different projects, piloting different scenarios. Are we going to lose time doing that? Probably yes. So for that, we will need to find out how to validate, method to validate robustness of the results of all those projects. We are already experiencing, we have so many projects all around Europe, joint actions, different results, but we don't know what, they're just forgotten after some years and nothing happens. So from both sides, they will have to fill up, to give the input to our standard development groups, if they will still exist, as I said. So we will have to use classical approach to enforce our evidence-based philosophy, but also maybe in the future we will be able, as an organization, we will grow, maybe we will be able not to conduct, but at least to coordinate different studies, maybe to initiate, to organize, something like that. We will see, that's a big deal. And we heard that this private-public communication and cooperation is definitely a future that we have to think about. So this is maybe also for this organization. The kind of EDQM is also something to think about, definitely. And then AI, we heard a lot today about this. It is present already for so many years. Like simple Google browser is using AI, not to mention everybody, all the companies that are trying to sell you something when you search for, I don't know, if you search for tendinitis, then you will be bombarded with ads about orthopedic shoes or something like that. So AI is here in everyday life. It's just we are not using it enough in science. So maybe we will be also monitoring results of our standards, the impact and how much they are used and are they useful at all, and maybe even monitoring our clinical results. That should not be waiting for 20 years. We should implement that in a much more near future. I don't know, maybe to organize centralized database for clinical research, investigation, something, I don't know, maybe AI can help with that, definitely, because the quantity of information is going to be enormous. And then we will try to close this cycle. And as also colleagues said, these days, definitely we will have to have much broader stakeholders than we have today. And as I said, we already do have enormous work groups and enormous number of people involved. So new things and new challenges, how we are going to communicate with all those stakeholders, with all those experts who will be giving their inputs in something that will have to be standard. So standard means this is validated, it works, it's a best practice, it's state of the art. I don't know. So what I don't know, why I don't know how we are going to deal with that is, will we be capable at all? Will our brains really develop that speed at that level? And if not us physically, maybe there will be some tools to support us, that our ideas will still be going on and something will do that work, like do this presentation instead of me doing my animation for hours. Would be nice. But if that happens, will still we be the ones who will be in charge in 20 years? So many questions, sorry, not so many answers.
So thank you very much, Vanya, for this very complex way to manage a much more complex question. Thank you for this. I was wondering if I should take my antidepressant now already, but I'm still seeing the glass half full, and I think you are as well. So with that said, I'd like to hand over to my co-chair.
Our theme for this afternoon is going to be positivity. Dr. Marks, can you hear me?
Can.
Excellent. Thank you so much. And without further ado, I'd like to introduce you to Dr. Peter Marks from the FDA.
Great, thanks. And I'll share my slides now. Hopefully that will work. Let's see if it happens. There we go. Okay, we will stay pop. Yeah, there you go. Should come up in full screen in a moment.
Yep, it did. Thank you.
Great, thanks very much. So this meshes nicely into the first and second talks. The first talk, a lot of the issues are around where we are headed, does have to do around the fact that global differences can be exploited for both good and bad. And I think we would like to make sure that we make the essentially global convergence help make regulating products as easy as possible and close some of the gaps that sometimes allow substandard products to find their way, or ineffective products to make their way to people. So, I think I'm going to talk about this in relation to cell and gene therapy, but it could be applied more broadly. So it's just that the case here for global regulatory convergence for products that serve small populations of individuals is very strong because the current situation of having global differences in this area of rare disease therapies is simply hindering access to patients in need. And it's not potentially, at least in my opinion, helping public health in each of our individual countries. So I think the idea here is to think about how we could do this better and improve global health. And I think the other piece of this is that there are low and middle income countries around the globe that will eventually, in the next decade, be seeing advanced medicinal products. And those advanced therapeutic products will need to be essentially deployed in a place where there is some knowledge of how to regulate them. And so there really is a need for global education now so that the people who are picking up the regulation of these in individual countries at least understand them. And even if they're not reviewing them directly, they at least understand the nature of what they're dealing with. And also want to just spend a few words about how this can really help us overcome some barriers. I think probably, right, the bottom line up front is that delivering safe and effective cell and gene therapies to those in need should be a global priority so we can reduce suffering from serious diseases by applying the scientific advances that we've developed. And I think it is global regulatory convergence in high-income countries could help facilitate the commercial availability and pave the way for the use of these gene therapies in low and middle income countries, in part because I suspect that, as in the first talk you heard, some of the advances that we will see come if we're able to make these products have essentially successive generations of advances, will reduce their cost by an order of magnitude or more and make them so that you could envision seeing them deployed in low and middle income countries. I'm going to focus for a moment on cell and gene therapies for rare disorders because there are literally thousands of these that could be addressed. And essentially, as we're seeing the deployment of genome editing and other technologies, we may see a transformation here of how we can address these diseases at a genetic level. And when you think about it, even many common diseases are probably essentially a collection of rare diseases when you look at the level of the gene. In the United States, we have now 22 approved products in this kind of more complex, either cell-based gene therapy or directly administered gene therapy space. It is, we've recently, as you can see here, if you look, we had the first approval in 2017. In 2023 and 2024, we've had an acceleration of the pace of approvals, and so these are and Europe mirrors this nicely, as does Japan. There's been an increasing pace of these approvals, yet it's not keeping up the pace with the number of diseases that need access. And if you looked at the products approved in the United States and the products approved in Europe, they're not identical, again, because the submissions have been made at different times. Some manufacturers decide not to take products into one regulatory jurisdiction or another, just because they don't have either the wherewithal to do so or don't see the potential benefit in doing so. So the idea here is to how can we make these products more accessible, again, not just in high-income countries, but also start to see them move to other places. So, I mean, I think the case for global regulatory convergence in high-income countries is that truly, and this is even taking into account the fact that there will be a price differential or reimbursement differential between different countries. We'll accept that that's going to happen. But in order to have commercial viability that's robust, for a gene therapy, you have to have at least about 100 gene therapy treatments per year for a systemic administered gene therapy, because otherwise, at least in US dollars, it just costs too much to manufacture and not able to make back what the cost of manufacturing is. Now, that is with today's generation of adeno-associated viral vectored gene therapies. That may change in the next decade as we move to directly administered CRISPR-Cas9 lipid nanoparticle or lipid scaffold or artificial capsid delivered gene editor therapies, which will probably cost a lot less. But one way to get there to make things commercially viable in a given country for a rare disease is to simply have more countries as potential markets, because then you can potentially get to a place of commercial viability for these products. But more so than in even in high-income countries, if you really think about it, low and middle-income countries potentially could benefit the most from gene therapy because of lack of access to adequate amounts of supportive care and the cost of supportive care. I mean, just do a thought experiment. Think about thalassemia major in the United States or Europe or Japan, for that matter. You know, these are places where you can provide adequate blood transfusion, adequate high-resolution phenotyping of blood cells, so you provide a very high-quality blood transfusion. You can provide high-quality iron chelation. You can measure patients' progress by using MRI to make sure they're not becoming iron overloaded. So people can actually now live a pretty normal lifespan. Women can actually have children. Things are really remarkable. That costs a lot of money and takes a lot of resources. And if you have a gene therapy, however, you can fix the problem once and for all, particularly if we can get to the point of directly administered gene therapies rather than cell-based gene therapies. That could be transformational in low and middle income countries, which will not they just simply in the next decade to envision that they're going to have the infrastructure to provide that kind of supportive care is actually less realistic than thinking about the fact that we might be able to advance, at least in my opinion, gene therapy to the point of directly administered products that could potentially be at least starting to be deployed. Now, to get there, we're probably going to have to rely on a regulatory framework or harmonized regulatory decisions that are equivalent to pre-qualification that could help facilitate access, because it's unrealistic to think of many nations that do not have highly developed regulatory systems in Africa or Asia developing large bodies of reviewers that are able to review gene therapies that are complex. I mean, it's hard enough in an organization. I can't speak for Europe, but I can speak for the U.S. It's hard enough in our organization to muster enough resources to keep the review of these happening timely, and we have hundreds of individuals involved, let alone regulatory authorities that sometimes only have a handful of people. So I think this concept of trying to get towards regulatory harmonization and the equivalent of pre-qualification for gene therapies to make it easier for low and middle income countries may be something we need to start thinking about. I'll say a little bit more about that. I've already kind of covered this, but just to say that, you know, the availability of a globally developed general regulatory framework could really help expedite patient access because for many of these countries, trying to develop a regulatory framework out of nothing could be quite challenging for them. The other thing that I'm not going to cover much more, but we're actually starting to see addressed in some ways, is this issue of manufacturing in lower middle income countries being a challenge. But one of the exciting things are the development of advanced manufacturing technologies that allow one to miniaturize some of the manufacture, particularly as we're seeing for mRNA-based technologies. Some of that technology can be miniaturized so that it can potentially be produced in relatively small production facilities of 1,000 square feet or less, involving only a few individuals controlling systems. So that may address production needs in some low and middle income countries. But in terms of practical next steps, there really is a more active harmonization of regulatory approaches in high income countries necessary. That's because for our existing gene therapies right now, we have ones that are falling out of commercial viability in front of our eyes. That happens both in the United States and in Europe. There are examples, and good examples, in both Europe and in the United States of products that have made it to market but then have been withdrawn from the market just because commercial viability has been a challenge. There's also many examples of products that are available in one or the other jurisdiction where they have not been submitted across the ocean because it was just viewed as too high a bar to overcome. So I think the idea here is we need to address that. So I will tell you a little bit about a regulatory pilot that we're doing to try to address that. And we also are trying to address this larger issue of the fact that low and middle income countries in the next decade will start to see these products that we have in high income countries, and we'd like to help them have the regulatory framework. And about now, it dates back 7 years ago, that kind of an effort was starting at the International Conference of Drug Regulatory Authorities to ask WHO to start to help with this education. We've been involved with that, and I'll tell you a bit more about that. So in terms of high income countries, we have a collaboration which has just recently started with the European Medicines Agency, trying to look to see if we can converge some of our regulatory approaches, resolve differences that are remaining, for instance, in what we need for manufacturing information, differences in what we might be expecting in terms of clinical trials. And that might allow us to, if we can resolve those differences, we could potentially have a regulatory submission that could be submitted at least to both of our agencies, but possibly even on a more global basis, because there is a separate pilot that's gone on in the oncology world called Project Orbis that's been run out of FDA. Rick Pazder has led that. And that project has shown that, at least with a number of countries, not including the European Medicines Agency, they've been able to do this very effectively. The current pilot has just started. If it goes well, we may expand that to a Project Orbis-like project, really because increasing the efficiency of the regulatory process, reducing time and cost, and potentially expanding these markets for companies may allow us to have more commercial viability. But most importantly, it may allow us to see more patients with rare diseases getting access to therapies in their home countries without having to travel across large distances. The other piece of this is that in this area of global regulatory convergence, we have been working with WHO. We've been also working with regional regulatory authorities like the African Regulators Network to try to help provide education in this area. The outcome of many of these efforts has been that WHO has progressed trying to get towards a regulatory framework. some of this regulatory framework has involved getting some convergence on what we describe as advanced therapy medicinal products. I won't go over that right now because actually the first talk went over a lot of the issues that came up with that. A lot of the discussion about trying to understand what represent true medical products, what are on the fringe, there was a workshop held in Muscat, Oman, this past summer that really had about 30 different regulatory authorities from about 4 continents, 4 or 5, four continents, yes, on it. There was a very robust discussion of a lot of the challenges. Again, many of the same things came up, challenges that we have with these products being very complex. The fact that around the legitimate products, there are often any number of products that are masquerading as products with efficacy that are essentially ineffective products such as some of those in the stem cell space or the exosome space, or some of the blood products that are used in all sorts of interesting ways. And so there was a lot of discussion about the help that was needed in low and middle income countries and in this area, because particularly for them, they noted that they are, it was a very heartening discussion. It was actually, compared to depression, it was very essentially engaging and encouraging, because many of the smaller countries in Africa and in Asia, Middle East, understood that they were potentially subject to manipulation because of their lack of resources in being able to understand some of these products. And they understood that there were a lot of people out there looking to potentially exploit that for profit. And so they were asking, they had a number of asks from WHO to help them in trying to understand the products. And there was relatively good agreement upon the need for a number of things, including regulatory capacity building, the need for international, regional, local guidelines on the regulation of cell, tissue, and gene therapies. This issue of regional reliance came up, and as instead of, even if you can't get to having WHO serve as a reference body as they do for vaccines, at least we could perhaps get to regional reliance, which could be very helpful. There was the feeling that there was a need for WHO standards to help with the cell, tissue, and gene therapy products, particularly advanced therapy and medicinal products. A lot of discussion around the technical assistance necessary, because, again, many of these regulatory authorities are run by a handful of people, and that's not even enough people to review one of these applications in a year, let alone the multitude that are likely to come along. And then there was kind of a request for regulatory reliance, which probably is the one way that is potentially most effective, because we have a good model with vaccine pre-qualification to rely on. But that model does mean it's resource intensive for WHO, and WHO has a challenge with resources. So those things, along with WHO standards, were things that were asked for. So I think ultimately we're at a place where hopefully educating more of the globe around the nature of these therapies will help us all, in part because it will help allow us to get these therapies to people in need. It will also help avoid, and this goes back towards the first talk as well, it will help avoid exploitation of populations with products that are ineffective, that can potentially be pervade in countries, low and middle income countries, just because the knowledge there is not there. So thanks so much for having me virtually, and really appreciate it.
Thank you, Dr. Marks. And then if our other presenters will come down.
So I'm sure we do have a bunch of questions, but only limited time. So I'd like to invite you to bring up the most burning points in front of our prestigious speakers. If I may start to ask Vanya, perhaps. Here she is. Hi. Just a question from your perspective as a supranational organization. As you see national incentives growing again now, like in Germany, the national strategy for cell and gene therapy, like the way Spain uses the hospital exemption clause in a way much different than other European countries. Are you seeing yourself as a sort of countermeasure to drive the convergence that Peter Marks was also alluding to?
Thank you for another difficult question. Right now, what our task is really publishing standards. So it has to be consensus. So it has to be useful and acceptable for everyone in EU, because from 27 it will be mandatory for EU member states, and useful for others as well. And again, it has to be state of the art. So yes, we are trying to do that. I mean, that would be the aim. But then again, is it always, we are trying to be realistic also, not to put things that that maybe do work fantastically for some country or very developed or something, and then not applicable for others. So it's a reasonable balance. We are not pushing, we cannot do that, and there's no reason. It's really always about consensus, but also trying to do something like a step-by-step improvement, but also trying to do something that is really state-of-the-art. We have, maybe to explain this, we have different, right now we are introducing different levels. So there is something that is really mandatory, there are recommendations, and then there are things like if you can do this, this is fantastic. So that's the kind of trying to harmonize.
I am Elisabetta Zanon from the Alliance for Regenerative Medicine. Thank you very much for the great presentations. It was extremely interesting. I have a question in terms of how we can reconcile the vision put forward by Dr. Marks in terms of harmonization at global level, trying to ensure that we move in the same direction. We have a framework which ultimately can allow to have more cell and gene therapies being approved across different jurisdictions in an easier, faster way, and ultimately this will result in greater patient access. With some of the calls that we hear about having more flexibility, at the same time at European level in terms of adapted pathways for less complex cell therapies, having adapted pathways for hospitals, having more flexibility in the way therapies are classified, whether they are medicinal products or if they remain substances of human origin because they have not undergone significant manipulation. So how we can reconcile these visions, which somewhat, they seem to me to go a little bit in opposite direction with the overall objective of ensuring patient access, of course. Thank you.
Yeah, this is Peter. I mean, I think this is an area where we're just going to have to decide as a global community what we want to try to do here. Many of these products are serving small populations where the benefit risk is such that I think in anyone's calculation, the ability to get access would hopefully outweigh some of our local differences that we might like to have for other products. I think part of the issue here is that for products that treat many, many, many patients, there could be local differences in how one wants to apply those products. Good example, GLP-1 agonists. I guess different countries could come to different ways that they might want to spend their resources. Some might want to have diet and exercise programs. Some might want to continue to fund the cost of those, and only deploy them when absolutely in absolutely last resort circumstances. So people could come to different conclusions there. But in the area of these rare diseases where you have potentially fatal diseases in very small numbers of individuals, the benefit risk should hopefully be reasonably clear and straightforward. And hopefully we could align on that, because the amount of extra work that we're creating is a disincentive, and it's ultimately counter to public health, I think, and it's leading to precisely what I think you were getting at, which is that in the United States we have a right to try program, which is essentially an easy way for certain actors to make products available that are not necessarily safe and effective, and that has happened because of this kind of call for access. So it is a challenge, but I do think it's one that if we as regulators put our mind to, I think we could potentially help solve, again, with support from others in the various countries. I'd be interested in others' thoughts about that.
Yes, I have a question. This is Jaap Zwaga from the Netherlands, and I was sparked by your talk, Peter, about rare patient groups which need our gene and cell therapies, and I was also triggered by Vanya that we probably need a disruptive way of looking at how we test nowadays our medication. Large trials, which are not possible in rare patients, cost an enormous amount of money. One of the products you put on your slide is $2 million per patient. So for rare patient, that will not fly. So I would rather provoke this and say, well, we need also an increasing permutations of therapies which have to be combined in patient groups, not single therapies combined there. We need other systems to test patients which are much more easily and fastly tested into the patient, real patient groups, and do testing on how they perform. Have responder, non-responder analysis in real life. So we should have a different way of accelerating getting new therapies in patients. So what are your thoughts on a different strategy to get these enormous amount of new drugs more easy on the patient? For example, post-marketing, performance rating, and paying for them.
Yeah, great question. Dank je wel voor deze vraag. Thank you so much. So I think where we are is in a place where we really need to think about making two things. First of all, I think you're absolutely right that we have to become more efficient in how we study these products. And that's something we're working on by trying to leverage the use of biomarkers, intermediate endpoints, and exactly what you're saying, trials that are more inclusive, that get to the endpoint of allowing us to make a determination that the products are likely effective more rapidly. That's one piece of it. The other piece of it, though, is we have to start to move to production of products that can cost us an order of magnitude less money. That's why as much as I love adeno-associated viral vector gene therapies, my hope is that as we are able to move towards a more synthetic biology of CRISPR-Cas9 delivered in either a lipid nanoparticle or on a lipid a lipid nanoparticle or on a scaffold or in an artificial capsid, that those will be an order of magnitude less expensive, which would still be too expensive for many countries, but it would at least be within not in the stratosphere. I couldn't agree with you more that we are in a position here in the United States where these $2 million gene therapies that we're approving, we, again, just so you understand, we don't set cost at the FDA, and we're not allowed to take cost by law into our account when we are approving a product, but we're very aware of the cost. I do agree with you. The cost needs to come down. Some of that has to do with the manufacturing, and some of it has to do with the efficiency of development, and we need to pull both levers there. It's a great question, and it gets to the heart of global sustainability, because it's not sustainable at the current pricing of these products.
Joaquin, we did cut you off. I'm sorry.
Yeah, now that we mentioned about sustainability, I would like to realize the potential of blood and tissue banks, especially those that have already have the infrastructure for the production of cell and gene therapies, and especially for those products that have been authorized by the EMA and they have been withdrawn. I mean, most of these withdrawals are just basically because of commercial reasons. So we are, let's say, not letting patients to access to these therapies. And I think that institutions like ours have the possibility to do that. Is the hospital exemption the best way to do it? Well, it's the only way to do it right now, unless you ask for each patient the compassionate use to the authorities that if this is a life-threatening condition, they will say yes, but if it's another type of condition, maybe they will say no. So and maybe that is not actually what we want. We want something that is more realistic and not using as a last line of treatment. So just a couple of words to realize this potential of institutions like ours in a public context.
So just one thing, we have a hard stop in 5 minutes. So I'm sorry to be the one to tell you that. But I'd be very, very interested to know about our friends from Brazil, from South Africa and elsewhere. Is this science fiction? Is this a reality? The way of doing this through networking that Kim described, do you see those models elsewhere? I'd really like to hear that perspective.
Thank you. Karen van der Berg from South Africa. These are all very, I think, laudable approaches, but for the African continent, and I'm trying to catch Claude's eye, I don't know that this is achievable. And we had a little bit of a controversial conversation yesterday as well around setting standards at a level that becomes unachievable and therefore limits access to certain groups. And Claude and I were having a conversation on the bus over here talking about the progressive realization of goals, where there's a minimum requirement that enables, for example, bone tissue from South Africa to move to Kenya, because we have surplus in South Africa and we can send to Kenya, and they don't at this point necessarily have the ability to produce their own. But the requirements for doing so is so onerous that it is not possible for us to comply, and so therefore we can't assist with that, within that. So I'm very concerned that we are in some instances using a very global north approach to try and address constraints where just having refrigeration. So we were talking about EQA programs and the inability for, even when the WHO pays for Sandbus to send EQA samples into the rest of Africa, just getting it through customs, maintaining the cold chain, to be able to get the samples to a blood bank in rural Cameroon is nearly impossible. And to then, on top of that, layer some of these standards and requirements without an understanding of the limitations in those areas, I think is going to cause problems for us to be expected to jump from where we are to where the international community thinks people should be going. Sorry.
Yeah. I have a question for the panel, just in terms of what Owen was referring to, science fiction. Some of what you're talking about seems far-fetched in terms of 20 years from now there might be a robot delivering this speech, and for animal testing we might be using synthetics and so on. Is it far-fetched, or is that the reality we're living in, where proliferation of information, and the slide on 4 years for doubling information, now it's 12 hours. Is that reality? It sounds like something out of sci-fi. Is it? What's your thoughts on it?
When I attend the meetings, usually you see two different ways to do the things. Either the miniaturization of processes that actually facilitate a lot the production of these therapies in a point of care, let's say, model. And then on the other side, you see the possibility of, and this is actually what we do at the Blood and Tissue Bank, is the possibility of scaling up the production of cells using bioreactors. This is something, of course, that can be automated. And actually, we consider artificial intelligence, particularly in the quality control, because we realize that the immediate thing that we can use the AI is basically in everything that has to do in preserving the quality of the intermediate products and the final products, and then the overall quality of these processes. And then once we have these banked cells, then we say, we tune them into what is of use of the patient in order to personalize the medicine. So this two different approach, where you can either miniaturize, and this will be fully automatic. So I can imagine hospitals having these machines the same way that you test the safety. So you could have the production of CAR-Ts next to in the pharmacy of the hospital. But then there is also this other option of requiring a facility for the expansion of a large number of cells, that then they will be at the very last point of fill and finish to complement the characteristic of these cells, either with a scaffolds or whatever thing that is needed. And I think that these are two very different models, and it will really depend on what is the condition. Again, we mentioned today the in vivo therapies. So maybe in the future everything is going to the gene therapy somehow. And I didn't mention this, but the technology that is considered in some of these in vivo CAR-Ts is actually the same liposomes that were used for the COVID-19 vaccination. So that is not using lentiviruses, but actually putting mRNA inside of the liposome. So this is really mind-blowing, and I think I cannot say much, because I cannot even myself see what is going to happen in the coming years. But yeah, in terms of automation and machines, I can see these two different models.
I'm Marcus from Brazil. We have a particular situation. Brazil have two parallel health systems, a private health system with 45 million people, and a public health system with 185 million people. And the classical example is CAR-T cell. For private system is a commercial offered the CAR-T. But in public system, we have developed the linking to University of São Paulo in-house CAR-T cells for viabilization of this therapy. The difference of costs is enormous, no? About $500 million for the private system, And we calculate $100 $100,000,000 for the public with the auto development. This is the situation in Brazil, unfortunately.
Yeah, thank you all very much. We will have to end here. I think we could probably talk about this for another hour. And going back to your question too, I think 20 years, it's hard to imagine really what it will look like, but drastically different from where we are today. And Dr. Marks, I'm sorry that you weren't able to join us here in Rome, but thank you for dialing in virtually. We do appreciate it. And thank you to both of our speakers and to my colleague, Martin. So thank you all, and it is time for lunch. Thank you.
All right, I think we will commence. So welcome back everybody for lunch, and it's with immense pleasure that I'm going to co-chair this session. It's going to be the final session of a really nice 2-day program, which I'm sure from all of the interaction that you've enjoyed tremendously. This last session is an ambitious one, with the title of From Forum 25 to Forum 30, suggesting that there's an arc and a trajectory, which I hope the 3 speakers will provide for us, and will perhaps concentrate our minds as to the discussions we've had over the last 2 days and compared to what we did 5 years ago. So without further ado, because we are running, I think, slightly behind time, so we're going to slightly shorten this session to about 1 hour and 15 minutes instead of 90 minutes. I think my co-chair and I will be quite brutal with the speakers to make sure that it's within 15 to 20 minutes, and we will haul you back to your chairs and if you go over time, so that we have lots of discussion. So on that note, I'll hand over to my co-chair to start things. Thank you. My name is Mickey Ko, for those. Exactly. I'm in such familiar company, I forget that, because I think I know many of you. So for those who don't know me, I'm a clinical hematologist working primarily in London, UK, managing a busy hematology unit with a specialist interest in cells and advanced therapy. So on that note, to my co-chair to introduce herself and the first speaker. Thank you.
I'm Indresh Kaur. I'm the Technical Director of the Cell Therapy Lab at MD Anderson Cancer Center in the US. And we're going to be talking about past, present, and future. We're going to be seeing what we have learned till now about MPHOs and where we are now in the field, and what do we anticipate in the next 5 years. And with that, I'll introduce our first speaker. Yeah, Dr. Tim Pruitt, please.
Yeah, thank you very much. So I'm a past president of ICCBBA, as the thing says up there. I am also a transplant surgeon. I've been involved with biovigilance stuff for a very long time. We were doing the back before the Disease Transmission Advisory Committee was an ad hoc group. I was on the ad hoc group, and we've been involved with safety of human products and most importantly organs for my particular bailiwick, and coming up with systems to try to at least move towards preemptive treatment early and prevent problems after transplantation. So that's been my interest in the biovigilance side. But as a past president of ICCBBA, I was at Forum 25. How many other people were at Forum 25? There we go. Oh, look at this. But not a lot. There are actually quite a few who weren't. So let us start to go through and to deal with this. I have no conflicts of interest other than I do advise for a company that makes medical products of human origin to try to prevent CMV disease. So first thing is to ask the question which Mickey asked last night, which is, what the heck is ICCBBA? And it was actually an important question because it helps define what the mission is. What's ICCBBA? What's ISBT 128? And why was there a Forum 25, not a Forum 2 or a Forum 1, but a Forum 25? So I'm going to tell you a story, the once upon a time story. The International Council for Commonality in Blood Banking Automation was established, and it had a 25th birthday. And that 25th birthday was Forum 25. Now, this is going to be the worst slide on my whole thing, so I'm going to apologize for it, but it's the only way I could put the history all together at one time. So the story of ICCBA is that it was born out of a need, and that need was to automate blood banking. It was not for the need of biovigilance. It was a matter of efficiency. Back in 1975 or so, there was increasing needs for automation. And so there was a contract that was established that established the Committee for Commonality in Blood Banking Automation, the ICCBBA, and it was established by a contract between the National Heart, Lung, and Blood Institute and the American Blood Commission. And a labeling code was created and adopted eventually by the American Red Cross, and it became known for all of you blood bankers out there as CODABAR. And that was about 1980, plus or minus a little bit. 1985 was recognized by the FDA. It was before Dr. Mark's time. Life was good. But there was a flaw in the methodology. The flaw was there was no formal process or mechanism to update it as things would change. And so what happened then is that blood processing changed, new technology came about, new products were introduced that were not incorporated into the old CODABAR system. And everybody kind of free-winged it. The AABB, the American Association of Blood Banks, and the ISBT, the International Society of Blood Transfusion, created a couple of independent committees to fix the code. In 1989, those guys got together and they agreed that it couldn't be fixed. And so they ditched it. And the societies, the blood banking societies, got together between 90 and 93. The American Association of Blood Banking, the International Society of Blood Transfusion, the American Red Cross, they met and created a new code. That was the ISBT 128, the International Society of Blood Transfusion Code 128. But they recognized the flaw in the old CODABAR. They said that what we need to do is not only have this, but we need to have a way to continuously update it, keep it relevant to the existing technology and changes. And so they developed a business plan. The Gulf War happened. We had all this blood that was coming in different sites, and everybody recognized the confusion of the language which was there. And then Baxter granted a 3-year grant. The Department of Defense, in order to fix their blood transfusion stuff, contracted for services, and ICCBA was formed in 1994. And so it was born out of necessity, born out of automation need. And the key for the ICCBA structure was a mechanism to maintain currency, was having the technical advisory groups, which would always go through, and as new stuff would come on, they'd say, we need a new code for this because we don't have a given setting to do it, and that's what we need to do. In 2013, ISBT recognized that, oh my God, we're way beyond blood now, and they changed the name to the International Standard of Blood and Transplant 128, incorporating the 128 characters in the ISO 7-bit character set, and that's where we are today. So that's just your little history story. That's who ICCBA is, and they moved from being the Committee for Commonality in Blood Banking and Automation to the International Council. But they got the same letters except for the I. So Form 25 came about because there was all sorts of stuff going on. It was recognized that there were still tremendous benefits associated with MPHO therapy, but that there's also problems. In fact, in Form 25, automation was only tangentially mentioned. Now the article on my left from the New York Times of last month, again, states the unbelievable benefit associated with MPHO, and this amnion. And it was a poor guy or woman who had been burned, and the properties with amniotic tissue in terms of regeneration, migration of epidermal cells and everything else, her face was remarkably benefited through MPHO. On the flip side is the one where the amniotic tissue was taken out of a woman and at the time of birth, and oh, by the way, there was M. hominis that was in the cervical canal, and it contaminated the tissue, and it caused problems in a whole slew of folks. And there's good, tremendous good, but inherent risk. And so the question is, how do you need to do? And it goes on to say, what do people need to know for their benefit, and what is it that needs to be, what is their risk, what needs to be on the label, which is sort of what with the whole thrust of the process was going. Manufactured medical devices, which was mentioned this morning, are typically linked to the manufacturing lots. The prevalent coding system we use globally today is GS1, as has been previously mentioned. And it's designed for supply chain management. But there is a lot of peculiarities about products that come from one person and go to another, or even the one product that comes from yourself and goes back to yourself in terms of what needs to be tracked and make sure that it stays the same. And the linkage with the human being who donated the product has to be maintained because it is unique well beyond any of the manufacturing components going through. So the value associated with MPO is in fact the value associated with the donor. The donor identification is essential part of the coding, which needs to be included. It has to have clinically relevant manufacturing processes, as noted through all the blood changes in blood work that has gone through. But biovigilance does require an ability to link both the donation component with all of the manipulations which go forward, and then you've got to keep in the supply chain management stuff, which leads to distribution, stockpiling, inventory management, utilization, all the different things associated with your healthcare system. And not most importantly, this is a bias from a transplant surgeon. Most importantly, there's different qualities of organs. Okay, there's different qualities in medical products of human origin. There's lots of benefit, but it's on a continuum. It's on a spectrum. For those of us who are transplanters, if I'm going to transplant an organ into somebody, I want an organ that's going to work for them for a very, very long period of time. When I have a guy who's this tall and this big and plays American football, he needs a lot of kidney. And if you give him a kidney from a little old lady, he's not going to come off dialysis. And matching what a person needs with what is available is fundamental to the appropriate use of MPHO. It's really exaggerated in the organ transplant space, but it's realistic and true all the way through all the other products which come through. I can just use my domain only as a way to accentuate the fact that there needs to be some sort of knowledge for the person who's going to be putting in whatever product it is, whether it's bone or skin or anything, as to what in the world they have in their hand that someone else is supposed to benefit from. So the MPHO labeling should facilitate recipient benefit and effectiveness and safety. But there are multiple stakeholders for MPHO. There's the recipient, there's a systems approach, and there's a regulatory component which goes forward. So Forum 25 was planned with all that stuff in the background. So Forum 25, Lisbon, 2019, it was great. It was a time to celebrate ICCBBA at 25 years later, and it was planned to be fun, and that's what it was. But it also raised an existential question. Why does ICCBBA exist? And in a large part, that we didn't answer that. Why wasn't ISBT, because we're having too much fun, but why wasn't ISBT 128, which was specifically designed for MPO, actually being used? Why hasn't it penetrated the market effectively, because it's done a pretty good job for the most part with blood, but it's still very heterogeneous across the globe as to why, or the use of products which were specifically designed to describe what is in the bag. So was there still a need for uniform standardized coding? Not only for blood, but for everything else? And the answer is probably yes. So the keynote talk was Luc Noel, and I think some of the people, specifically anybody from the WHO, know him, and he gave a very long thing on a historical perspective of medical products of human origin, and spoke very particularly about the unbelievable benefit that occurs, but also as being from a blood banker at the time when HIV and HCV was transmitted through lots of blood products in the early 80s and 90s. It recognized that governmental authorities played a huge key in ensuring product safety. The globalization of the MPHU was real and common. WHO made efforts to address safety, and they had all sorts of different programs which they started, which you've heard about. I'm not going to go through them all. The 25th year of the ICCBBA was oversight of ISBT 128, and it was really clear at that time that ISBT 128, it was not just about blood. There were lots of different products, minimally manipulated homologous use tissues, corneas, ocular stuff, cells for ART, but back then we were expanding into some of the stem cells, gene therapy, and the lymphocytes modified for in vitro tumor infiltration and infection, organoids, organs, milk for infants, microbiota for gut repopulation. And the topics were challenges of traceability, unregulated activities, future challenges, genetic, vigilance and surveillance, and informatics and technology. Sort of sounds familiar. And then COVID-19 happened. And we had the meeting in 2019, and we had COVID-19 at the end of that year, and essentially everything was demonstrated that systems are fragile, supply chains can be broken, and vigilance and surveillance goes out the window. These are our recommendations. 16 recommendations, and there's lots of responsibilities of the government, the WHO, professional organizations, and essentially nothing happened. Probably mostly because of COVID, but because of, again, the fragility of the systems. What I want to end on is the whole concept of common language. Common language is a powerful tool. Even God recognized it. The Tower of Babel is a testament to common language. In early times, all mankind spoke a single language, and they decided that they were going to build a tower to the heavens, and it was working. They were getting up to the place where they could, in theory, see God. And God said, look, they are one people, and they have one language, and this was only the beginning of what they will do. Nothing, stop that. Nothing that they will propose to do will be impossible for them. So he confused their languages, made multiple languages, made tribes, nations, all sorts of stuff. And guess what? The Tower of Babel failed. So the question now going through this is, where do we go? Do we continue with multiple languages, a global language? MPHO are used globally. It's here. But we have no common language on how we address all the plethora of problems of which we have thus far seen. For the sake of efficiency, safety, appropriate use, blah, 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 the notion of commonality needs to be readdressed. So the issues in 2024, we have multiple languages, codes, etc. The EU has just come up with their language, and which is going to be it's already been passed, and it's going to be implemented in 2027. The US, we just did a biovigilance gap analysis of what we do. We came up with innumerable recommendations, which we will probably not have many accepted. But as you heard from the other things, we are continuing to make new products. The current codes are even more confusing as you move forward into complexity, as you look at nanoparticle introduction of gene therapy, we are going to be talking an explosion of products, which the people who get these things, they have a right to know the benefit and the risk associated with it. We're also moving into biopreservation, xenotransplantation. It's just going on. So global biovigilance requires a basic infrastructure. The surveillance and identity quarantine of risky MPHO should not be implanted. In addition, it is necessary to identify recipients of these products to mitigate disease. The ultimate person who deserves to be protected is the one who's going to get it, and they're the ones who are least likely to know what they're getting. So we're not there yet. There was a reason for Form 30 and probably Form 35, 40, 45, and 50, assuming it was still here. Thank you.
Thanks, Tim, for sticking to time. You did, actually. That rang automatically, not me. But anyway, thank you as past president for setting the kind of framework for ICCBA and also what Forum 25 did and achieved. We'll now hear from the current and president of ICCBA, who will present the current situation over the last 2 days. So with great pleasure, my colleague and I think long-term friend, Dr. Zbigniew Szeporowski. Did I get that right?
Very close.
Yeah. See, God did teach us to speak in multiple languages, so we learned over lunch. Over to you, Ziggy, as most people would know you.
Thank you, Nikki, very much, and thank you for all of you for being still here for us. And for the next 10, 15 minutes, I'll try to tell you what you heard before, which I'm not going to do, because I'm not going to offend your intelligence. I know you're here, I know you listen to what was said, and I'm going to say a little bit different things, just for fun, if I can follow. All right. So on the bottom of this slide, and now on this slide, we see what we actually set ourselves as a goal for this meeting. Achieving and sustaining a global consensus for medical products of human origin, safety, biovigilance, and traceability, and to protect patients in need of MPHO worldwide. It's highly naive of us to think that actually we can accomplish that. So that was just a setting goal, high level, maybe we do it, maybe we don't. But a lot of work went into it, Form 30, and I think this is what I'd like to review with you. Okay, so first of all, international contributions. So first of all, how many of you are from different countries? There are 36 countries represented here, coming from different parts of the world, which is very critical for us. Many of you presented or co-chaired sessions, so those here. Again, you're representing a very diverse world. And I think we also learned during the discussions we had that we all come from different perspectives, and those perspectives have to be understood to actually move forward, make any progress. Because I came from a country when I was born in which we didn't have many things, and these things change with life. So from donor to patient. So now I will offend your intelligence for a moment, but only to remind you how fantastic a road we took since yesterday morning till today. So first with the welcome session, that was kind of okay session. I understand there was a bunch of people talking about it. That we moved to need, safety, and risk and availability. That was critical setup to basically talk to you about where all those balance may actually exist, where the balance exists. Then we moved to threats. I mean, we always worry about something done to our patients who actually will shorten their lifespan, or we create some damage to them. I think that's a very critical component of thinking between the donor and the patient. Then we moved to the breakout sessions, which I thought was a stroke of brilliance. I'm sure it was Owen who thought about it, or somebody thought about it, because it gave all of you an opportunity to actually, in a smaller setting, give your thoughts about what you think about part. And here's what you come up with. First of all, I think they were brilliantly explained yesterday by three speakers. They did a fantastic job to summarize a very complex discussions. But there were certain topics which were sort of consistently present in all three groups. One was the regulations. And I think hearing Peter remarks today, who is a good friend, I have to say he's a very optimistic person. And that's what it is. This is great. And the reality of our lives has been that if we talk to anybody in the industry, they would say regulations are the biggest barrier to actually moving things forward. So that was that, including, someone actually mentioned including awareness. Standardization is such a great word, but it means different things to different people. And we even heard yesterday universal quality indicators. We even don't standardize those. Manufacturing, how you manufacture components. All those things have a variability, which is huge. But standardization sounds like a good solution to some of the problems, but not all of them. Training education, that's always a good thing. I think we not only have to educate ourselves, we have to educate public. I think one of the important parts of our life is to educate public. What do we offer and what does happen to you? Because as we've heard from a patient representative yesterday, the patient's lives are so different than what we experience till we become patients ourselves. So I think this is critical that we train not only ourselves, we educate ourselves, but also educate our legislators. We educate, so advocacy is very important. We educate people who in the future will be using the products we make now. Information technology, there was a lot of fantastic session this morning, a lot of information. I think information technology is critical. We all believe this is a solution to everything, but on the flip side, I don't think that's what's going to happen a long time. But AI, and consensus development, that we've heard today also from our speaker that you have 100 people in the room, you have about 120 different ideas, yes, how to do things. So more people you bring in, the more difficult it is to actually accomplish consensus. And that's why the consensus, even in this room, would be difficult to accomplish, but we learn from each other a lot, and I think that's a critical part. And central repository of anything is difficult to accomplish. However, that's also something which was raised during those breakout sessions. And finally, we heard that too, that forum or like activities are helpful to at least discuss what we need to struggle with or what we can have solutions. And I think this forum, as Tim mentioned, it happens every 5 years. I think something like that, or bringing people from different walks of life and different experiences, might be extremely helpful long term. So I think there's something which the board of ICCBA will be, I'm sure, discussing after this meeting. So then we move to the when things go wrong. We talked about that, yes, and it was also mentioned by Tim today as well. And select MPHO across complex pathways. So this is this morning sessions, still fresh in our memories, fantastic discussions, great presentations, and technology with trust, I just mentioned that. And the last 20 years, with regulators telling us how things may actually happen, and I hope that it will. However, I'm not as optimistic as Peter might be, and not as pessimistic as Vanya can be, because I think there's somewhere in between where we can find a pathway going forward. And finally, this will be the session today, and I will continue this. So when we measure, when we presented, when we opened this symposium yesterday, or this forum yesterday, we thought about three things. Uniqueness of this, and I think we hopefully all agree that is a unique platform. We see people here which we otherwise would not met in our lives, completely different. We're interactive. I'm hoping that you all had a chance to be interactive, to say what you think. If you didn't, you have an opportunity later on. But having said that, communicate with us, communicate what would you like to say to us. And finally, forward-looking. I think we have presentations, what's going to happen in 5 years, 10 years. Someone said is predicting the future is very difficult, yes, but it's easy in politics because you usually don't live long enough to live with the consequences of what you predicted. Now, that's the important thing. That's something of a Churchillian of here. And now we're moving to what's happening with ICCBA. And I thought I would talk to Owen yesterday, and I feel this is very important for this audience to understand where ICCBA is trying to go. And maybe, we hope, maybe, we'll be answering some of the questions which you had in your mind as you were listening to different presentations. So in our strategy plan, we have the support, globalize, and stay relevant. And I will go through all of them as we discussed with the board just a couple days ago. So support, what it means for the people who actually use ICCBA, ISBT 128. The more education, webinars, online person, not every user in the same. We actually recognize that people in different parts of the world, different even jurisdictions may require different type of training or education. We do implement. And also implementation of assessment. Unfortunately, this is really bad for me because this dropped down, sorry. And then what I'm saying is that I was looking at people's slides and realizing they're kind of getting out of range because this is a different program. Okay, user group. We recognize that we need to work with vendors people who actually provide it. We need to work with the facilities and the regulations and offer a vendor-specific processes as well. In terms of globalization, I think, again, we are we hope we're one big village, but I think many people have different approach to that. So content in other languages. Clearly, we have not a Tower of Babel anymore, so we have to speak hundreds of languages in this world. But at least we're going to think about, again, Spanish and French as one of the next, at least the gateway to there. More presence in regional events, we plan on that, assign local development officers. We think that this is very important Because as we look at different countries, how they implemented ISBT 128, there were different models. One country cannot describe what happens in different country. Each country, Poland was different than Brazil, Brazil was different than the United States, and so forth and so on. So I think that's important to remember. Make implementation modular. We realize the implementation right now seems overwhelming to many. And I think how do we make it actually easier for everyone in small places? Prioritize MPHOs are distributed and accessible license fees for low and medium income countries. That's very important for us too, because we don't want to create barriers. We want to open the ISBT 128 to as many jurisdictions as possible. And then finally, they stay relevant. I think this also goes to Tim's conversation. When you look at ISBT 128 from the outside, or ICCBA, you can see yourself, why it even exists? Well, obviously, we have a role, and we hope that's actually an important role. But staying relevant, it also means to grow all the time. It's actually getting better as we go. And we've heard about HL7 fire today. We also talk about EHRs, and we have some progress done with EPIC recently. That's important. And incorporate technology that enhances our tech support. So all those things are critical. And finally, respond to new terminology needs. As you know, we spend a lot of time creating new terminologies, and that's important because it's a language we start with. We have nice papers with ISCT where we actually describe MSCs, for example. People could not agree on MSCs, mesenchymal stem cells. But the reality is that when you bring people together, they come up with something relatively simple solutions to those issues. This is our problem. Our problem is that if you're looking at in the world, we are not the same. Different parts of the world have different resources. And I think that's critical to recognize. And we as ICCBA, we want to recognize the fact that we really want to be helpful to lower middle income countries and low income countries to actually adopting ISBT 128 or just adopting technologies. And again, we discussed, the representative from South Africa mentioned to us that, it's great, but you're spending money maybe in the places we shouldn't and should spend. They have better solutions. Anyway, so this is the story. And what happens next, we did create an enterprise grant. Enablement awardees for this year, 2024, were announced, and this is basically advancing global safety. And those are the listed here who were awarded. They're not limited in any space or form. Any group of people can apply for that. There are some description how to do it. We very much hope to do it in 2025 and following years. Idea behind it is to provide even limited resources to individuals or groups which are interested in basically building ISBT 128 in their jurisdictions, in their places. So if you ever want to think, if you have people who you think might be benefiting from that, let's let them know at the next one will be time in 2025. And finally, that's what we started with. Obviously, we didn't get consensus, but I think what Owen tells me, that is basically what we have in this group is sort of a reflection of real life landscape. We are all coming from different areas. We all use different MPHOs. And I think hearing representations from people who I never met before, but also never heard speaking or never heard about topics they talk, I think is very critical for us. So hopefully we all learn something and we're all going to absorb that. And finally, thank you for all of you. I apologize, usually doesn't happen that way. And I give some time back to Mickey. Did I?
Very well done, Ziggy.
Thank you.
Thanks very much, actually, for the very nice presentation summarizing what the objectives and strategic aims of ICCBA are and also running through the last 2 days. So we come to our final speaker, and I must say that for any meeting, it's always very nice to have WHO present because it not only lends an air of gravitas, but also of endorsement to the entire meeting and also provides, I think, a framework that we can immediately speak to WHO about various issues that we're facing. So very pleased to have Stratos, as you all know, I think, from WHO, speaking about the future. So over across to Mr. F. Stratos Katziros. Not bad? No. We'll get there. maybe while we're doing the slides, for audience members, as we come to discussion, maybe I just want you to think about what has been talked about last 2 days, the slides that have been shown, and think, is there any area that's not been covered that we can talk about in the discussion? So have a little think about that. Cross.
Okay, thank you, Mickey, for taking some of my time. When I was asked to talk about the future, actually, I thought I would consult my crystal ball, but it turned out that it was fake one. It didn't give me a good provision. So I'll try to actually, the presentation is just to set the ground actually for the discussion that will come up afterwards. Talking about future, what we did in actually a couple of years ago in WHO with our science division, we did the horizon scanning of what is the future actually in health. And we came up with about 100 new innovations. And as you can see, they were grouped in 8 categories. And I was very surprised to see that 2 of those categories referred actually to MPHO. Indeed, as we've seen from the previous session also, MPHO is a growing sector, especially with all these new technologies, the ATMPs and the new medicines and devices and whatever is coming up that involves some sort of human substance. So indeed, if we narrow it down and things that have been heard maybe in the previous sessions again, we've seen about cell and gene therapies, very comprehensive analysis. We have regenerative medicine, a lot of stem cells that are going to treating other conditions, not just the homologous use, if we would say it like that. We have immunogenetics now that are improving in order to avoid the rejection of organs and therefore increasing the lifetime, the survival rates, and therefore reducing the need for more transplants, for a new transplant, because we have also that problem that after rejections, you want to go to a second transplant, and therefore we are highly immunized. And creates also an additional burden on the waiting list. We have organ preservation techniques, machine perfusions that are increasing, so the devices sector, increasing the quality of the organs, and of course, better outcomes. I want to highlight the last category, the donor alternatives, because that will be crucial for our discussions. So we are still depending on humans, and we call substances of human origin or MPHO, whatever, but the HO is still there. So are we able to still depend on humans in the future? The growing needs of diseases, the burden, the pressure is immense. If we're talking about gaps, this is one gap that we cannot close. And indeed, we need to look into the alternative sources of products. If our scope is to treat the patients, it's not about just increasing the availability of MPHO and therefore securing maybe our jobs. So bioprinting, xenotransplantation, artificial organs, these are all in the pipeline. So maybe we need to speed up and of course, look into a balanced approach when we are talking about the future. From a WHO perspective, talking about the future, unfortunately, as Mickey said, it's nice to have us in those meetings, but we have also our own restrictions. So the way that WHO works, actually WHO, let me just explain, we are a consortium of 194 member states, and therefore the decision-making body of WHO is the governments, the ministries of those countries, the World Health Assembly, that decides, and they give us the priorities. They give us the mandate of what we need to work on. It's not that we take an initiative and we say, oh, you know, you need to work on MPHO, you member state. No, they come back to us and say, this is our direction because we fund you, we govern you, and this is what you need to do for us. And this is the restriction. But nevertheless, we still try to find some loopholes and still put, of course, our programs into that perspective of what the countries need. This is the general program of work, the 13th, as we call it. Of course, it's the 13th that is already finishing. So the 14th one is what's coming up in 25. you see the priorities. These have been set by the member states in consultation, of course, with the WHO, our regional offices, and I'm glad to have all my colleagues here that support us. And of course, the directions, as you see in those six categories, I'm sure you're trying to find where do we fit into that. And so our department is access to medicines and health products, and this is where the MPHO program is based. So this is what we identify ourselves under priority 3 and 4, which is to advance primary healthcare approach and essential health system capacities for universal health coverage. So this is to strengthen the health systems, first of all, and the other one is to improve the health service coverage and financial protection of the people. And of course, there's the fifth one, which is the emergencies. And we did talk about these emergencies in the previous sessions. So under these broader strategic objectives, we will be contributing to those outcomes, which will be actually to provide the products that are necessary in order to achieve these goals. So therefore, one is the disease burden. The other thing is how do you treat that? So therefore, what kind of products you would be needing in order to reach that objective. Starting from blood, which is the most common MPHO, we identify these challenges, and practically you will see from our global database, we still don't have also a clear picture because, as you can see, we only have 92 countries reporting. So from 194 countries, as I said, we only have a small percentage of reports that come in, and you can see also summarize what are the big issues. I know this is the subject of this meeting is safety, biovigilance, but as you can see, it's one of the elements. The biggest issue that we have is lack of availability and access to the products. And of course, this translates also to the lack of development in the systems of governance, of services, and that translates to availability. And of course, when you have the products, then the availability might be reduced if the quality is not good and the safety. So we had established an action framework for blood a few years that also expired in 2023. And from that action framework, we designed the strategic objectives were to actually deal with those insufficiencies that I showed in the previous slide. So this is the series of publications and guidance documents that came out from that action framework addressing all these issues, how to strengthen the blood services, the systems, how to increase the availability of quality plasma that would be leading to the plasma-derived medicines, how to better manage the patients, the patient blood management guidelines that we have in order to reduce also the usage of blood, unnecessary use, if we may say, which might be translated in other areas as a wastage also, or other things as prevention also by reducing the need for certain MPHOs. So I'm not going to go through all these. I'm happy to share the slides, of course, and you can find them on our website. Practically, sorry, just to go back. Just to say that in that action framework, as I said, it has expired. So we are now actually discussing on what comes next. So looking into the future, we have our advisory groups. Actually, we'll be meeting next year, but we are already reflecting on the implementation of those activities, how we disseminate all these products. We already have this week, actually, there's been a workshop going on parallel to this meeting, and another one would come in December. And we try to engage with the member state authorities and the regulators, and of course the professionals at the same time. I'm happy to see a lot of our collaborating centers here also from blood, from other areas that are supporting the dissemination and the implementation of those products. And I think that will be a critical discussion of the outcomes of that meeting that will feed into all our designs for what comes next. Coming into my personal area, so which is the organ, tissues, and cells, the transplantation program, we have been working actually what is in the pipeline. I'm just showing you briefly in the sake of time. We are working on a policy brief on tissue donation transplantation. This is a document that describes the role of a competent authority. We aspire to increase the awareness on the need for tissues, what are tissues used for, and therefore what measures need to be put in place. And we have the tissue compendium. This is a joint project with ICCBA, and we're very grateful for that. That is based on the standards that Karen showed us, and this is in a way to promote the harmonization, the common language, and this will come out also as a joint product with the policy brief, and therefore we hope that at the government level we will sort of have some impact in regulation. We have also another policy brief that will come up about the competent authorities' role, which is not just the tissues. This is a broader one for organs and cells. This is looking at the regulatory perspective as well for other products. And the last one is as an assessment tool that we want to design, which is for measuring the capacity of the countries in the development and the regulation of those products. And this can be used as a benchmarking exercise as well. I would like to mention that we already have a regulatory benchmarking tool, the global benchmarking tool that is used for medicines and has been adapted for blood and has been used. And therefore, we need to expand that to other MPHOs as well. And I come down to the other products now, which are not the standard, let's say, ones, organ, tissues, and cells for transplantation. As it was mentioned, the MPHO framework, I think Dolores mentioned that yesterday, was a document that we produced in 2017, and therefore it was not fully accepted, if I may say, at the Assembly at the time. It was just noted by the Assembly saying that, okay, we like what you're saying, but then just keep on working on it without any specific request. So other products that were included, milk and other, we have like cell and gene therapies now coming up, and assisted reproduction. So these were categories that were not included under the standard transplantation or blood program, although we have departments in WHO that have been showing an interest in this approach. So the sexual and reproduction health, the nutrition department and child development, and of course the biologic standardization department unit that is working on the cell and gene therapies. So we have been contributing to that. The most developed one is that with the milk, and I'm glad to have our colleagues also that are supporting this. And ICCBA has been supporting as an observer also in the development of guidelines for human milk donation and banking. And hopefully this will come up early next year. And the one that Peter Marks already mentioned earlier, the document on the convergence for cell and gene therapies has already been published, but we're working on further implementation now. And of course, now the gamete donation and banking that has been I was recently approached by our department, our colleagues, looking that more countries are interested now in this, although we might realize, and I don't know, I'm sorry for my colleagues from that area, that this is more of a higher income countries that are involved in assisted reproduction, although fertility treatments are not an issue for our other programs. Reproduction is mostly looking to fertility treatments rather than assisted reproduction, and therefore has not been expressed as a priority or a need within WHO. Hopefully things are changing. So we come to the Santander Summit, and we have the recommendations that came out. Again, this was shown yesterday, so in the sake of time, I would not repeat those. However, this was focusing again on the clinical use of SOHOs, of substances of human origin, MPHOs, highlighting the issue especially for those novel products that need to be equally regulated. And of course, the basic principles, this was the main issue, especially when it comes to the voluntary unpaid donation and the commercialization of the products, and therefore the margin of profit that is allowed. We heard a very nice discussion about also how a single treatment might cost millions, and therefore the accessibility as a big issue. All of these have fed into a new resolution that was presented by Spain, and we thank Spain for all the initiatives that have been taken and the support that have been provided to WHO. And practically is the only government has been raising these issues at the global level within the Health Assembly. With the support, of course, of other countries that came afterwards, they produced this resolution that was adopted in May last year. And I'm just highlighting some of the requirements for the member states to do. A resolution usually has two components. One is there's a background that explains why this has been introduced, what are the issues, but then there's a request for what member states, authorities need to do. This is the commitment that the member states will take. And then there's another chapter, which is what member states are asking WHO to do. So this is, I'm just highlighting those issues here. First of all, to designate authorities, member states need to have, and this is something that we're opening the discussion already, and you need to start reflecting. We need to have a designation of authorities in order to improve the governance. We need to have authorization of centers, monitoring, accreditation, inspection of centers because this is something that we know that, especially when it's uncontrolled institutions. We need to promote, of course, the safety and efficacy. This is where we come now to our discussion. Therefore, we need the data on outcomes as well, not just on the activities. And we need to know that what we are doing is good and safe. Of course, the preparedness plans in event of crisis. This has been discussed also as an element, as Ziggy showed. And of course, the regulatory frameworks that need to be applicable to the new innovative therapies. All these are responsibilities. So we come down to what WHO has been asked to do with this resolution is practically to assist the countries and guide them on how to develop the regulation. So there's an element of strengthen the capacities of the countries in regulatory capacity in monitoring and evaluation. So this means tracing, vigilance systems, traceability. But of course, to provide the technical assistance on how to strengthen on the ground as trainings and guidance. And also what is interesting on the guiding principles have been established in 2010. They were renewed in 2010 about all this unpaid donation, the consent. They are asking us now to include the novel therapies under those principles, but that needs to come out of a consensus, and that will be a big challenge when we're going to be discussing these issues. The last point is the global strategy that we have been asked to develop in order to implement all this under a common framework and objectives. So data collection is remaining, as always, a critical element for all the resolutions, and this is the only way that we can monitor the progress and report back on the achievements that we have made. So the global strategy, and we're finishing with this because we will be opening the discussion, is a document that we need to produce for 2026 for the Assembly to adopt. So I think this is the main driver of our work for the future. And what we are discussing at the current time, and thank you for that meeting that is included as part of the formal process for the global strategy, because we're having all these formal consultations with different bodies. So you are all part of this. And what we have been saying that what we are trying to achieve with the global strategy, we have been talking about national sufficiency in products of human origin, but we are changing a little bit now. We're looking into what the patient needs. It's not about the country achieving a national sufficiency, because there might be many types of treatments. I've been hearing a lot from the organ perspective. Sometimes they tell me, you need to start with a living kidney program. So what about the heart program? So you let the people die because you want to start with the kidneys? No, it's about what the patient needs, and this is a patient-centered approach. So this is where we need to set the goals that by the end of 10 years from now, that all patients will have access to the treatment that they actually need. So this is a big objective, of course, and we have to debate on that. But nevertheless, this comes down to the pillars. One is availability, the other one is access to the products, and then we go to the safety and quality. So key elements of a global strategy, this is something that we have to consider. There are different pillars, again, the different levels that we need to target the strategy. We need to have the population on board, of course, because they are the basis, they are the donors, but they are also the users, the patient associations that we heard also yesterday. They need to be aware, of course, and they need to come up and step up and make those demands and the political pressure that needs to come from the bottoms up from the society. Then we have the hospitals, sorry, and the healthcare professionals. And here I would like to stress also that the demand for the use of MPHO will come from the health professionals, not from us in the sector, but the people outside of our group, the orthopedic surgeons, the other types of, the ophthalmologists that will be demanding those specific products to be used because they are comparatively better, affordable to other types of products, artificial or whatever, or other techniques. But this means that they need to be trained and aware of those because what we see is not happening. And of course, we come down to the national authorities. This is the responsibility overall. We see also in the implementation that is critical that we need to define the actors, the partnerships, and the funding. Usually when WHO is in a room, everyone comes and knocking up on our door and said, well, help us. This is not for us to provide the resources, but we can mobilize the resources, the partnerships that are necessary. We need, therefore, to have an investment case. This information, this strategy will be sort of a document that will be put up and say this would attract the funding and the different NGOs or other institutions that will be willing to support the development. And we're closing. I'm going to go through this because we're already over time, and you will see that there are 5 strategic objectives here, and I'm going to go very quickly because it's already mentioned in the previous slides. The first objective will be to strengthen the national health system. So that means the organization of systems, which comes down to legislation, regulation, oversight, the availability of authorities, and of course the financing and sustainable financing for the services. Vigilance and surveillance will come down as a function of the national authority and the oversight. And of course, data collection systems, harmonization, all these are sort of like managerial, let's say, aspects of the system. We come down to the donation programs, and we, just to mention that we are talking about all cells, tissues, and organs. So it's very difficult sometimes to differentiate. We heard yesterday that our tissues are in the wagon of organs. We want to have a space for each product to be clearly defined and to be equally acknowledged. So the critical elements for all are the availability of infrastructure, the centers, the equipment, the availability of trained professionals, and of course, the public awareness when it comes to the donation. When it comes to the transplantation as well, the use, the implantation, or whatever we call it, we also need the professionals, again, to be trained, the infrastructure, the centers, and the equipment, but you also need the health coverage, because if you're going to talk about patients' access, who is going to pay for those services? So this comes down to the policies again. Maybe that's interlinked with the first objective. And of course, it's not just the coverage. Here is also the referral. So from the primary healthcare, how are people going to be referred to a waiting list, to a service, saying that this is what you need for your treatment. So this comes down to the professional capacity to identify the need for an MPHO as part of that treatment. Then we come to the 4th and the 5th, which I think this will be controversial and will be under discussion. What will happen if we acknowledge that a country cannot have all the programs? There is a national insufficiency. Either they are poor, either they are small in numbers, they don't have enough donors. Do we let these people die or do not have access to treatment? There needs to be some sort of agreement, of exchange, of support of people that might be able to go to another country to have a transplant, but under certain conditions and agreements without having that burden on the people themselves, the financial burden, or the burden on the society that receives those patients as a donor society. And of course, in the emergency situations where you have a disruption of the chain of supply, where you would need to go into that collaboration. The last part is to, as I said in the beginning, we need to promote the research and development of all the alternatives because we might not be able ever to reach the gap depending on human donations. And with that, I'm closing. This is the last slide. It's just showing you the timeline where we are now. We are establishing an expert committee, and we'll be making soon a call. So you may be applying if you want to join that committee. It will be a very restricted number, so the selection process will be rigid. But nevertheless, we will have the opportunity also with you to work. And we are developing the draft document that will be going into a public web-based consultation. So you will have another opportunity to contribute with your comments and views before we go afterwards to member state consultation. So once we have your expert opinions, then we will take that document to the member states, to the governments, and we will have on a region by region consultation with them saying, is this what you want? Is this okay with you? And we need to get that consensus. Once we do that, we wrap it up, we bring it to the Assembly in 2026, and hopefully it will be adopted. So discussion is open on how you want us to proceed. Thank you very much.
Can we please invite the speakers on the podium? We'd like to invite questions for the speakers. Thinking about the last 2 days that we've spent and the discussions we've been having, and also I know everybody will have a lot of questions for Stratus, but please raise your hands if you have any questions.
So, Pierre Tabergian, I guess with two hats, one being the European Blood Alliance, CBA, as well as ISBT, now code 128, with the International Society for Blood Transfusion. I first would like to thank the organizers. This has been a wonderful 2 days, very enlightening, thought-provoking for me. I come back with much better understanding of the issue. So Ziggy, you were wondering if we would come back having learned something. Yes, the answer is a massive yes. Thinking about what we've heard over the two days, I would like to make the following comment. And so over the last 15 years, I've been more in transfusion medicine than in cells and organs or ART. But what did strike me, and in particular, I think Martin Bergel yesterday morning, I don't know if he's still with us today or not, but he made a comparison between how things were approached, on the side of blood components and on the side of organs transplantation, and I would think also ART. And I think what struck me as pushing that a bit further was to say that in transfusion, we're very much driven by safety. Organ transplant tissue, ART, driven by outcome. So this may be an oversimplification, but still, it does strike me, it doesn't mean that transplanters are not interested in safety or that transfusers are not interested in outcome. But clearly, the issues are quite different, and there is the fact that we're able to trace the recipients of organs, of ART and tissues, I think a bit more easily than we trace our recipients of transfusion. It allows for organ transplantation and assimilated approaches to be very much driven by this issue of outcome, while we in transfusion, if the transfusion is okay, if we have a nice code, the nice number, we have the nice product, the quality control, it went into the patient, no immediate adverse events, all is fine. And obviously that's very wrong. We really need to go much more into looking into mid or long-term outcomes in a transfusion medicine. So how does that link to what we've discussed about traceability? Yesterday, Joe Visum was asking us, are we happy with traceability in our own, let's say, fields? And I must say that I'm not happy with regard to what's going on in the field of transfusion, because traceability goes up until what's going on at the transfusion, but then it stops. Basically, we're unable currently to follow up mid or long-term effects in these recipients. And so I guess I would call for the best link possible in between all the efforts around traceability onto what's being developed, which are comprehensive national, European, worldwide health data systems, which will allow us together to be able to assess an essential, obviously, endpoint for the patients, which is the issue of outcome. And I would just finish by mentioning some of the issues we have in Europe, which I think could be perspectives, interesting perspectives. We've touched upon, it's been discussed, the SOHO regulation in Europe. So acronym used in a European way here, but EU way, but still among that, there are issues such as a SOHO platform, which will be generating data. There's an issue of linking this with the European health data space. So all that's very, I think, strong perspectives and potential if we can appropriately link all the traceability up to what's going on at time of transfusion with subsequent events. And if we're able to do that appropriately, it's going to be, I think, a major progress with regard to what we can provide to our recipients.
Any comments from that very nice kind of summary and viewpoint? Any comments from the speakers?
I think when we talk about traceability, I think people are talking about various different things. And you're talking about outcomes. Yes, when we have products under clinical trials, and there is a follow-up of the patients, a short-term and a long-term. And yes, there could be some instances or some cases or some treatments where long-term follow-up is not there. But in the field of cell and gene therapy, we have recently seen publications about secondary tumors. Those are the long-term effects of some CAR-Ts. So yes, it's not in every field, but it's getting there. And I feel that all other areas need to have long-term follow-ups. It is important. It's important.
And just to add on, maybe I'll make a few comments, Pierre. I think what you have said actually provides an opportunity for us, for ICCBA, because traceability for a long time has just been this thing, that allows you to connect A to B to C, but to the average end user or clinician, that doesn't resonate with them. But if you convert the idea that traceability becomes your template or your instrument to then examine clinical outcomes, I think that's a very powerful tool. So I think your comment is extremely timely and really is something I think the ICCBA board does discuss at length, that we should be thinking of traceability not as an end to itself, but as an instrument for providing data and linking to, as you said, all the various health systems that come through. My other comment with transfusion medicine, I think you're also right, but I'm also to some extent heartened that actually, if you look at it, the last 10 years has generated a fair amount of evidence-based transfusion outcomes to do with whether it's liberal transfusion, restrictive transfusion, and then at the end, coming to actually specific subgroups. So I think it is happening also in the transfusion field, maybe a little bit less robust because of this precautionary principle and the idea of safety. But the point well taken. Sorry, Mecca, you're next. You could just introduce yourself and then again, okay. Thanks.
Madhat Askar from Qatar University, representing the International Transplantation Society. So actually along the same lines about the other face of the coin, the safety. I think, is there a concern that trying to put everything in the same platform because the issues are very different. In solid organ, the main pressing issue is global organ shortage. In bone marrow, we have tens of millions of donors to choose from, and everything is elective by design, so we have all the time in the world to do all testing we want. In solid organ, we don't. In solid organ, we infect the people knowingly with HCV infected organs and treat them post-transplant because otherwise they would die. So how do we make sure that things do not have unintended consequences when we try to have universal platform regulation?
I think the main issue on that one is knowing what your product is that you're transplanting. And I think that's going to be the same for bone marrow transplant as well as organs. things which are in very short supply or things which are in relatively in excess. So, but knowledge and accurate clarification about what you have is essential for good care. And I think that's the part of what we need to do. And to the end of what you were saying, Pierre, is that making sure it's not just about the immediate post-time transplantation, it's the long-term follow-up and making sure that people actually get something that we call health, which we don't know what that is. We call it that. And our systems measure different things. Our systems measure money and charge captures. Other people measure different things. But the goal here for everything should be to make people better. Better than what? Better than how? But all that we can say with what we do today is that you can follow something. And that's why I do believe that putting it into a coding system that can interactive link with global health would be useful. It's pie in the sky, but it would be very useful as a tool, is to figure out, do we actually do anything good with all of what we do?
Also, I think ultimately it is like looking at the risk to benefit ratio. And yes, I am transplanting some, a recipient with an organ, and my testing shows they have this issue. Now, can that issue be treated? So looking at your risk to benefit ratio, that I think is important too.
Thank you. Simonetta Pupella, Italian National Blood Center. I fully agree on what Pierre said before, and we discussed it a little bit in the breakout session 1 about the problem of maintenance of traceability in a long term. And I think it is necessary to open mind to the possibility to link our system connected with the MPHO with the general health system. Because the story of the donors in the long term and the story of the patient in the long term, it is absolutely impossible to link each other if we are not in the healthcare system. So we have to convince the politician to invest in the healthcare system. We talked yesterday about the health folder of each individual, who could be the place where we may find relevant information related to the health, and the person could be a donor and then became a patient, and the patient could be a patient receiving an MPHO. So I think in the view of the traceability, we have to find a way to open to the other healthcare system.
Absolutely agree. Thank you. Any comments to that? Yes, from India.
Thank you. At the outset, I want to really thank you for inviting me here. And, I think, when you look at organ donation and MPHO or tissue donation, when you look at it from 1 is equal to 8 plus 200, which are talking about certain common things between solid organ donation and tissue or MPHO. I think, if I looked at the Forum 25 achievements, and ethics was there in 2 places, I think we need to have some common ground, which Midat also was bringing up, I think, where we need to have the solid organ donation and tissue donation talking the same issues, especially when it comes to ethics. And we should have some exchange where we could have representation from you guys in our organizations and you here, but we're really talking the same thing. And I think that is essential, and that should be considered, and especially with WHO being on board on both the sides. So I think that's something which we need to address, especially when it comes to organ shortage or organ trafficking, or whether it also deals with tissue. So that's one thing I wanted to comment on. And the second thing, which I think is for a developing country like ours and other developing countries, you may call it Global South, which represents 80% of the world population. I think if some kind of a toolkit is developed by people like ICCBA, where the minimum good standards can be taken forward in that country when we go forward. And one thing which I was thinking is that at least we don't commit the same errors which you guys did coming so far. We could, fast forward. So, those kind of things could be documented, that you don't do these things. With technology especially could be used to our advantage. I think that's possible. And my request to ICCBA would be to look at these and see how we can collaborate, especially look at those, Global South. That is where your bigger challenges are, because you guys have sorted out a lot of things yourself here. So I think that's one of the key things which ICCBA should always consider when you call for such meetings. Thank you.
Yeah, that's something would offer a tip to countries which are developing the program. They should not be spending time and effort on developing standards. They are already available. Please use them as a guide. There could be some things that you want to change as per your country, but the basic standards, if you follow those, you will save time and not use your resources, which are scarce anyway, to develop standards. So don't just follow, the standards that have already been developed. People have spent a lot of time developing those standards, and years have been spent doing that.
Thank you. Please.
Thank you, Mickey. I think I echo the sentiments that my colleagues have actually said, that traceability should then be used as a vehicle to actually then promote the safety. And rather than focusing on the product itself, it is actually the safety of the donors as well as the recipients that should be the focus. And my ask is actually more about whatever we have actually discussed here. How do we then not come back in 5 years and actually say we were not able to actually do that due to pandemic or not? So it's more a responsibility for all of us then. How do we actually then map these recommendations to tangible actions? What can we take? And whether each one of us, now all of us would be thinking, what do I take away from this meeting? Yes, at a personal level and individual level, all of us have. But coming together, the powerful sum of all the organizations that are actually sitting in this room, what can we do to actually influence? And I think whether it is WHO guidance or guidance from different organizations, I think, even reflecting on what we bring out at SHOT as well, we do know there is a big chasm between the implementation, from these recommendations to action. So I think it is really what can we do differently to actually then implement these and make tangible changes.
Absolutely right. I think that's, that I think is obviously the goal, and I'll defer to our current president, who will answer you on that question and give you the answer.
No, I think it's absolutely true that we all wake up with the same way. Yes, we have a lot of energy after this meeting, I'm sure. You go to your workplace and energy goes away, and home issues and so forth all coming along. I think a part of the plan and Owen's plan going forward with this particular Forum 30 is to basically fairly quickly produce maybe a couple of event documents. And we have lots of information here. And most likely circle back to you, all of you who are here, and ask, do you feel this actually reflects what we discussed? But in reality, we all know that we function in a microcosm of politics and everything else, and money is primarily a driver. I feel that is important for us to recognize that we cannot move everything ourselves, and I think organizations which are in this room and people from all the continents may be very, very helpful to us to make it forward. So this is sort of a critical mass. I want one more comment to what Pierre said. I feel like, and I'm looking at the watch, I know it's going to be kicked from here in a few seconds, the reality is that transfusion medicine, and I struggle with that. I'm getting older, I have more struggle with that. We assume that we help people with transfusing people, yes? That's our assumption. That's because it feels good. But the reality is actually very difficult to prove that you actually make anybody better by transfusing them. So it's, in this case, bone marrow transplantation or organ transplantation or tissue is something when you have physical proof that the patient who was on dialysis now can actually avoid dialysis. People who heart was falling apart in CHF, now he actually can go and run. All those things are visible. I think what Stratos was talking about patient-centric, I think we often forget what is the most important for the patient. Because yes, we create new things. We feel good about those new things. but are we actually helping the patient in the end? So I think that's here, I've sort of odd positions, but in this one, I find difficulty for me sometimes to find easy way to prove that in transfusion world, we actually helping people who bleed, yes, but other prophylactic transfusions, we find that they are not very helpful to many people. So I think we have to be very careful because each of the areas, in my opinion, is different, as we just discussed. Each of them has different measures and different indicators of success. I think our success for the transfusion will be very simply, we don't infect people with bad diseases. That would be a very significant achievement. Although I must admit, sometimes I disagree with at least our government in terms of how many things we test for the better for us. Anyway, so that's the...
Thank you. Question, please.
Yeah, this brings me to an important point. We all more or less agree on the content of guidelines, but what we often forget is an implementation plan, because usually implementation is outside our hands. It's with third parties which play a role. But what we could do is design parameters to just measure how effective a certain change in a guideline is. For example, if we look at Pierre, restrictive use of blood is a common default, but can we really measure how many patients are really restrictively transfused? We have designed some quality indicators, and we can steer upon these quality indicators, give lectures, give education, etc., and improve, because it's measurable. If you have a guideline which is not measurable, forget it. And so you need to also look at guidelines and even laws. Just laws running through a traffic sign. If you can't measure whether a law has an effect, well, you should start maybe again. I would like to add to Pierre's, we don't need to also only measure safety or outcome, which is difficult in transfusion medicine because it's multi-parameter, but that is a reason why we have to aggregate data sets. With ICCBA, we can also measure prudent use. So how long a product is within an institution, how long it's stored, whether it's outdating. So it's a very nice tool because a lot happens in institutions which influence quality and which influences prudent use. For example, 1 unit use of red blood cell transfusion, great measure, saves about 20% of blood to transfuse only 1 unit. Can we measure that? With ICCBA, we can look at how many units are in one patient and etc. So we can do a lot more with data if we look at prudent use.
Thank you. And I think Joe might have a response to that or comment.
Yes, and in a way, it's taking that concept of new data that we should all be looking at together, even a step or two further. Quite a few of the items that we've been talking about, for instance, what's the level of traceability? Do we know how many MPHOs are applied in our facilities? Quite a few of those are areas where also there could be agreement on certain parameters, which maybe in 5 years' time, a worldwide group like this one could look at together and see what progress have we made. Maybe not in having more data, but perhaps in having a convergence of what actual types of figures should we be looking at together. Quite a few of these components are already in the SOHO regulation that we've been talking about, but the great strength of this gathering is that we've been going beyond the European Union and we have representatives from all the continents of the world. So I think there is something that ICCBA and WHO, perhaps as the truly global organizations which are leading in this gathering, could take things forward in important ways. Thank you.
Thank you, Joe. Any other comments or? Carlos, of course, yeah.
I just want to thank you for all this. I mean, that has been the change in the, as I said, the global program of work. The change now in the perception also from WHO is that we have produced enough guidelines. We have produced a lot of documents that just sit on a shelf and no one is doing something about them. So it's a waste of money in a way. Of course, what we are looking now in the next time period is to have an impact on the country level, on the ground, and therefore looking into implementation. And that's the shift now in all the mentality, in all the programs. And this is where we need, first of all, to raise the awareness of the, I mean, when you talk about the national level implementation, it's not up to you as individuals or our centers to implement something, because this has comes down from a national regulation or organization. It's not up to a single hospital to implement something. So we are the political advocacy and the bottoms-up approach. Perhaps this is where your role might be as societies, as individuals, as professionals. From our perspective, we go from a up to down approach. We talk with the governments. So we have the different fora, the meetings, the political level, where we will try to disseminate this information. And of course, we have our presence also within the countries, with our country offices like embassies of WHO that will be also reinforced in order to strengthen that communication. So they will be disseminating directly and have that dialogue with the governments at the country level. And then will come also from your perspective, the support. So we're sort of like tackling the governments. I think that's a key issue here from different points, that we're circulating them and claiming them in order to push for more implementation. Thank you.
Thanks very much. I think on that note, we will conclude this session. And just to quickly summarize, we have dealt with a bewildering amount of topics, from IT to cell and gene products. I think the issue that traceability is important is probably something that everybody agrees with now. We don't need to deal with that. But the next step forward really is to identify outcome indicators and how we improve on this traceability. So on that note, I think I'll close this session. Thank you very much to all three speakers for fantastic talks. And I think I'll hand you across back to our current president, who will summarize the meeting in the last 2 days. Thank you all.
Thank you. This is how my brain looks right now. Someone scattered. I'll explain in a few seconds what it is. Also, just to add, implementation science, which I think Pierre could comment on a lot, it's ISBT is also one of the goals for this year, I think for 2 years. So you will present see more of the ISBT work on the implementation of the guidelines and implementation science. Am I correct if I'm stating? Okay, thanks, Pierre.
This QR code is the survey.
Okay. Hey, I will tell you, I know what it is. Yeah.
Oh, you know it.
You think it's my brain? Hi, this is really bad. This is really bad. All right. So we have right now about 9 minutes, and that's a good news for all of you, because otherwise buses would go away, would be walking. So this is the survey, if you don't mind looking at that. Allegedly, it takes about 2 minutes. It was tested by Chris. And what I'd like to do, not working? I don't say, but if... Yeah. So if you could do that in the meantime, I'll be saying things, so you can completely ignore what I'm saying. But what I'd like to ask our esteemed colleagues here to basically closing remarks for us. You already had summary of the presentations today, and as I said, we're about 7 minutes before the buses show up. So from ICCBBA perspective, I think we're absolutely grateful to all of you for your time and your commitment, your discussion, everything you've done here. We learned a lot, and I think we all learned. And I really, really hope that this will continue. There were some statements about to this effect. Now I would just go, strategy goes first. Next. Any closing remarks? And then.
I think I've spoken enough for today. Well, I'm very, very grateful for the organizers, ICCBBA, CNT, CNS, for all this wonderful hosting. The initiative, first of all, by ICCBBA for this happy birthday for the 30th year, successful year. We really appreciate all your contributions. As I said from the beginning, also, you were great. You were selected for this reason. And of course, we continue working with you. I'm really glad that I've seen new people from the previous forum. And I look forward to the Forum 35, or maybe even sooner, we don't know. I just want to wish everyone safe travels, and our contacts are always available, and please do engage with us whenever you need, and we'll be always there to respond. Thank you so much.
Well, as an attendee and the co-organizers, as I look back to these 2 days, 3 words come to my mind. One is ambition. As we discussed for the very first time the program with Owen, I thought that this program was quite ambitious. Because, but I think that in the end, you all have succeeded to make these 2 days really interesting, because there was not only theory but also practice. So a visionary look into the future, but also a sound analysis of present challenges. The second word is cross-fertilization, that for those who are around the EU tables these last years is always mentioned. And it's not only among here stakeholders and different fields of expertise, but also among, for example, perspective from different countries who have different problems and different levels of maybe development, but want to avoid the mistakes that other countries have already done. And the third word is commitment, because if we want this to have a sound result, obviously it's we need medium-term, long-term commitments from international society, but also from competent authorities and from experts who should continue to give their inputs. That's it. Thanks for coming. Have a nice trip back.
Don't worry, I have just one slide. You probably know that those 3 persons. In center is Karl Steiner, who was discovered in 1901, the ABO group. On the left side is Adriano Sturli. Together, Alfred von de Castello discovered the AB group in 1902. And on the right side is Edwin Kohn, who in the 30s developed the process for fractionation of plasma. So can you imagine from 1901 to the 30s, a long period, in order to have the first fractionation of a substance of human origin into medicinal product of human origin. And from that moment on, as Vanya said today, every day is coming up something, and because the speed of progress of development of medicine medical products from human origin is going rapidly faster. The other historical quotation I would like to do is related to the measure, to the need of measure. The man who you see on that medal in the table down is Galileo Galilei, who wrote in Latin, omnia metire quecumque licet et in mensa ad mensuram tempestive redige. That means measure everything you can, and if something has no unit of measure, find it out immediately. So from the 17th century, we know that we have to measure everything in the field of research. And I would say that in these 2 days, I was really very happy to be with you, and the availability of substances of human origin for direct clinical use or as raw materials for production of medicines involves several critical steps, but more or less the same, beginning with the recruitment of potential donors, who must undergo a meticulous selection process aimed at identifying population at low or very low risk for transmissible diseases, and following collection extensive testing to detect a wide range of pathogens and other health issues. And only after passing these initial screenings, so from donors can be considered eligible for therapeutic use. So a long path, everywhere in this long path, we have to measure, we have to trace, we have to identify risk, and we have to find out solution for avoiding negative consequences. And in these 2 days, together, we have explored this process in several aspects. From the point of view, I start from the point of view of the regulatory aspect because I act as a regulatory agency. And all this process must be performed in a very controlled and regulated environment, granting quality, safety, and traceability with this large extent of the meaning of the word to the final products. And we are normally inspired by the hematopoietic stem cell transplantation model, where an interdisciplinary team involving the SAW establishment and all the actors, internal and external to the facility care, interested in the clinical application, can promote donation collection, substance processing, preservation, distribution, resembling the process that we do in the blood establishment normally. And we talked about the recent adoption of the European regulation on substances of human origin, and which is interesting because it expands the scope of the regulation to include previously unregulated substances, or to create a new regulating pathway for the production of novelties. But however, as outlined this morning, a global regulatory convergence is required for overcoming barriers to delivering therapies to patients throughout the world. It's not only a matter of the European Union. Personally, but I saw many of you, all of you, we had a lot of interest during this conference around the rapidly evolving technologies applicable to the concept of digital health, which has undergone an impressive transformation, and mainly after COVID-19. However, the implementation of digital health is not without challenges and concerns, and the primary concerns are security, privacy of patient data, but we cannot forget the need of education of professionals, the need of education of patients, and the need of education of public opinion. Mainly to avoid the use of products that are of unproven efficacy, which cost a lot and give nothing to the health of the people. And despite these challenges and concern, it is undeniable that digital health has revolutionized critical care and will continue to do so. And in the field of medicinal products of human origin, this is particularly true because this is the field that can benefit from deep learning, big data analysis, Internet of the Things, and footprints of the products to guarantee to the patient access to safe, sufficient, and equitable supply of medicines. But with the outbreak of the many diseases that we have during the history of our products coming from human origin, the need for rapid traceability of data, donors, processing and testing distribution is now again a high priority. We know that in every part of the world we set legislative reference for standards of quality and safety intended for the collection, testing, processing, storage, and distribution of substances of human origin, because the supply of this product has two different elements: the manufacturing of products controlled by product liability, and the consumption in healthcare protected by the consumer, or the patient right. And both must be taken into consideration when we talk about the responsibility that we have in this long process, starting from the donor and going to the recipients. We are really indebted to ICCBBA, who organized this relevant meeting in Rome, giving us the opportunity to get a deeper insight into these topics, with a common aim of increasing quality and safety of the medicinal products of human origin. We are at the same time grateful to all of you for the highly professional contribution given to the discussion and recommendation that are now or very soon publicly available to the benefit of all of us. And thanks again, and arrivederci.
So I was also hoping to, first of all, thank all of you for coming and have a safe trip, but also I hope to have a round of applause for all those who helped us to actually make it a successful meeting here and there, whoever the microphones. Really grateful to all of you. Thank you. And also to Owen and his team here, which worked very, very hard to make it happen. So thank you very much. Have a very safe trip home. And remember not to forget us. We'll be back to you. We're done, paper. Oh, there's one more request. So don't run away. Should take a picture outside. Yes? In front of this blue big thing. I of course have to think, where's the photographer? He's right there. He was fantastic. Thank you, sir.